meticulously crafted by Dr. Himanshu Matalia, and is co-moderated by Dr. Chintan Malhotra. And without any further delay, I shall hand it over to him. Dr. Himanshu, all yours.
Thank you, Dr. Geeta, and very good evening to everybody. I'm not going to take much time because we'll be eating up time from the case presentation, but it's my pleasure to invite all my panelists who are across the country. Our past president, Dr. Nikhil Gokhale, current president, Dr. Geeta, Dr. Namrata Sharma, and I'm really thankful to her because she was busy at a couple of places and she still spared time with us. Dr. Sujata Mohan from Chennai, Dr. Bhaskar from Chennai, Dr. Bhupesh Bagga from LV Prasad, Hyderabad, Dr. Rishi Sarup from Hyderabad, Dr. Ashish Nagpal from Ahmedabad, Dr. J.K. Reddy from Coimbatore, and we are your host, Dr. Chintan Malhotra from Chandigarh, and I'm Himanshu. So we'll start with the first couple of cases which are FLEP related. And Dr. Namrata Sharma is going to help us out with those things. Can we have the first case, please?
Yeah. Good evening, everyone. Shall I start?
Yes, please go ahead.
Yeah. Next slide. We all know that the revision of the traumatic classic flap associated with the epithelial ingrowth would lead to the most unpleasant complication of recurrence of epithelial ingrowth and flap knot. So in my presentation, I would discuss the tips to be followed during surgical revision of traumatic classic flap to prevent the epithelial ingrowth. Next slide. My patient is a 33-year-old female with history of LASIK done 10 years back. She presented during the lockdown period with a defective vision left-right, and her vision was 6/18, and she gave history of a trivial blunt trauma by child's fingers. On examination, her left eye revealed vertically folded and temporally displaced flap with epithelial ingrowth involving the visual axis. Next slide. The important surgical steps would be the epithelial debridement, then identification of the flap edge and the unfolding of the flap, folded flap, and then lifting and scraping of the epithelium beyond the flap margin. Next slide. And the scraping of the epithelial growth from the stromal bed as well as from the undersurface of the flap, and thorough washing, usage of MMC, and then stretching of the flap and suturing of the flap. Next slide. Please play the video. The epithelium was gently debrided using an alcohol dip sponge, preferably the epithelium removed from the hinge to the inferior flap margin in that direction. The flap margin is then identified with a femto flap lifter. I used this because it was easier, the edge was blunt and it was easier to identify the flap edge. Even the folded edge was also easily unfolded with the femto flap lifter. Then epithelium ingrowth from the stromal bed was scraped, and the epithelium from the flap margin all around 2 mm beyond the flap margins all around were removed to ensure that after handling of the flap, no epithelial nest enters into the interface. And thorough washing was done after usage of the MMC, 0.04% for 2 minutes, and then BSS wash was given for another 1 minute. Then gently the epithelial ingrowth from the undersurface of the flap was done with the blunt side of the Tooth's knife. And while removing the epithelial ingrowth from the undersurface of the flap, the folded flap was also gently stitched. Again, the washing was done from the stromal bed, and the next important step would be the stretching of the traumatic flap, which was done with a 2 dry wet sponge, and then ironing of the flap was done over the stromal bed 2 to 3 times with the wet sponge. And then the most important thing would be suturing of the flap. Why that suturing was done in this case? This mechanical stretching of the flap would avoid the future flap striae in the post-operative period, and also this stretching will ensure complete opposition of the flap to the stroma, and it will definitely prevents the epithelial ingrowth recurrence. The post-operative period was uneventful. Next slide. The patient was on, next slide please. The patient was on topical steroids in tapering doses for 5 weeks, and the plain topical antibiotics was given for 2 weeks, and doxycycline was given BD for 1 week and OD for 1 week, and suture removal was done after 6 weeks post-op. And it's almost 1 year now after the lockdown. Now there's no recurrence noted, and her uncorrected visual acuity was 6B. Next slide. Thank you.
Can we have the second case?
Yeah.
I think the case is open for discussion now, Himanshu.
Dr. Namrata, we'll finish both and then we'll.
Okay, perfect. Yeah.
So they're pretty similar. That's why we are stacking them together. It's a video by Dr. Deepti Mehra. And can we have the video, please?
A very optimistic girl. Hello, everyone. So this was a 24-year-old girl. It was 3 weeks post-LASIK, a very optimistic girl who had 6 parts vision with a little complaints of halos and glare. So the question was to intervene or no, and after a lot of discussions, both of us decided we should intervene. And this was the 5-step surgery that we performed, and let's see how it went. So the first step is basically to release the macrostriae, which can be only and only performed by removal of the epithelium. So epithelial removal here was done by assistance with alcohol. The entire epithelium of the flap was removed. Ensure that the gutter has no epithelium, and also a small rim around the gutter should be epithelial free to avoid any ingrowth. So the next step is to swell up the cornea, which could be achieved by a good wash over and under the flap by distilled water. The next would be to iron out the striae. This could be very well achieved by a semi-wet 2-sponge application technique, where the sponges are massaged parallel to each other to try to iron off the striae. The fourth step is what we feel is most important, that is application of heat. So here we have used preheated hockey sticks to try to massage out the striae. The fifth would be to keep the flap stretched. This was achieved by application of 3 interrupted sutures, basically in an intention that the striae don't recoil back. So here is the end of surgery. A PCL is applied. And this is the way we heated up the instrument. A few swipes of the hockey stick over a flame is good enough, and a manual check to make sure the instruments are just optimally warm. So this was the pre-op and the 1 week post-op picture. And this slide says it all. Her main complaints were due to the higher order aberrations, which dropped from around 0.6 to around 0.3. And these are the pre and the post retro videos, which shows that the striae have totally disappeared. Thank you.
Thank you, Deepti. And Dr. Namrata, over to you.
So I think both the cases were very nice and very well presented. And I think the ideal management was done for both the cases in the settings that was given. For the purpose of discussion, we can discuss a few things regarding, whenever you have a case of a flap which has been dislodged traumatically, or whenever there are any flap stria, we saw that both the cases they used application of sutures. But Anita, would you like to comment on that as to whether suture should be used, or whether you could use glue also? Some people use glue also and just leave it like that. And which cases would you like to suture? What would be the size of the dislocation when you would like to suture? And we know that when there are dislocated flaps which are not as much as you showed in your case, you could probably just refloat them back.
I decided to suture this case because it was 2 months old flap or a folded flap, and it was the fixed area. The fold was fixed, and it was while stitching, it was unable. We were unable to stitch it. So I thought, previously, I have done 2 other cases and post-operatively some fixed folds were there. So those cases had a recurrence of the striae after not suturing. So I thought, let me suture this case. And there's 2 cases I've managed with traumatic flap,
The
and
kind
one case of
the kind
flap
of
striae.
epithelial ingrowth you saw, Anita, in that case
Yes,
where traumatic flap dislocation occurred, I think occurred over a period of 2 months.
yes, ma'am.
So do you think that it could occur so rapidly, or do you think it was there before?
That I was not sure, ma'am.
Yeah,
But
sure.
it must
But you get
be
that
following the
florid
trauma.
epithelial ingrowth in the center.
Yes, ma'am. The
Because
thing
see,
was, she presented like 1 month before only. Before the like
Dr.
we
Reddy,
did a surgical revision only after 2 weeks, ma'am.
oh,
So with 2 weeks back, when she presented itself, that epithelial ingrowth was slowly progressing.
because see, when epithelial ingrowth occurs, even for normal flaps, I mean, it's not within the first 2 months, it's later than that. So I just was thinking, Dr. Reddy, would you like to comment on the epithelial ingrowth?
Yes, they are an excellent management. I saw this beautiful both the videos, and as he said, 2 months old, nobody want to take a risk, do the best possible like suturing, but usually few days old. Nowadays we are applying glue. Long time back we used to suture, but for the first few years we shifted to the glue. A little bit glue. We should not apply too much. A little one drop, one drop. They are doing very well. That's what I saw in my own cases. So, but
Dr. Namrata, if you have to take suture, can you guide us? Can you tell us how many sutures are? Because I saw Dipti took 2, Anita
yeah.
took I think 4 or 6. Not sure how many.
Seven
Sutures.
sutures.
So what is the ideal number, and what depth we should take? How tight we should take, and how long we can keep? Dr. Namrata, can you guide us?
So regarding the sutures, I think it is important that you really don't have to take a full thickness suture. Just like you take sutures, you have to oppose the flap with the edges. An important thing is that there should be no conduit, no space. That is the aim of the surgery. And the sutures can be longish sutures. They need not be very short sutures, and the depth would be, on one side it will be about, say 90% of the flap edge, and then going into the keratectomy edge site onto the patient's own, you can say, the keratectomy, from the keratectomy edge you can take, but again it need not be very deep. So it can be just along the keratectomy edge and just along the flap. But when you're doing it from the flap, best would be that you do from 90% thickness rather than the full thickness, because you don't want any conduit or any space to be left there. So it
And
has
how
to
tight
be.
we take the suture, and which side we bury the knots?
Okay, so like always, we would like to bury the knots not onto the flap side but onto the other side.
Wait.
And it can be, the suture can be tight. The only thing is the tension should be equitably, distributed, because you don't want it to be tight from one side and not so tight from the other. Then that microscopic or that submicroscopic alignment will not happen. So the idea is that you want to, of course, whatever you may do, you will not be able to microscopically align it at the place from which the flap had been created. But the best is to allow the flap as it falls down, because logically it would, just like you do for elastic flap. I mean, you don't make an attempt to go and align it. You just put it back, and then it kind of just fits into the place where it should. So one should not be too aggressive in tightening the sutures also in this case. Such
So
cases
other
are there.
interesting thing was that Anita removed the epithelium from beyond the flap margin also, and I didn't see Dipti doing that. Does it make any difference that we go for the epithelial removal beyond the flap margin also, as in beyond the margin of the bed also?
So
So
I also did remove the epithelium, not too much, maybe around a millimeter. Basically, when I lifted the flap, I didn't want the epithelium to go inside. So above the gutter and the few area I did went. I just edited that in the
So it is probably logical to remove the epithelium from that area because you don't want it to go again. And having said that, there are no studies which have compared, leaving the epithelium and not leaving the epithelium, and then comparing the two sets of cases or comparing that cohort. Probably because you don't have so many cases, so many such cases to compare. Also, whenever you are putting any cannula in that interface, it is best that when you take it out and you have to say do a wash again, it is best that you change the cannula and do not put that cannula again, because then you'll be implanting the epithelial cells again. So when you sit for such a case, you have to tell your scrubbing nurse that you would need, about 5, 6 cannulas. So you are going to be changing it each time you want to manipulate in the interface, and not put that thing again and again. Even in normal, I think, LASIK cases, one should do that practice so that you don't have any epithelial ingrowth.
Dr. JK, when we are on flap-related complication, I would ask you one thing that similar to this thing, intra-op, if we have free cap, and if it flips, then how do we decide, how do we understand which is epithelial side, which is stroma side, and how do you solve that if you have intraoperatively a free cap kind of?
Usually what I found is if you put the cap in a small bowel, whatever is there available with VSS, and leave it for a few minutes, it will nicely show which is convex side, convex. It comes to the normal contour. If you put on flat surface, it's very difficult. You just leave it in a bowl of normal VSS, normal temperature, not very cool. And it usually shows up very nicely like a contact lens. Then you catch it, then you have to remember which side is convex, which side. The other way around is what I did it is when I put on a gloved finger and try to, when I'm sure this is epithelium side, once we decided under the microscope looking at the sheen of the epithelium or the stromal side, try to identify. Then whatever you decided is the epithelium that you keep top. Then I try to scrape that with a Sinski hook and see whether I am getting epithelium out. If I don't get the epithelium out, then most of the times you get the epithelium loosening. Then you are sure your epithelium is that side. That's how I managed few of my cases in my practice.
Thank you. So nice. Any other panelists have any comment?
So even by because when we used to do microkeratome LASIK cases, and we used to have a free cap therein, we always used to give those peripheral marks with a gentian violet, and so the epithelium side would always have those gentian violet, those circles, which are intersecting onto the area of the flap as well as onto the area beyond the keratectomy edge. So if you can still see that, you can still make out and try to align those once you have a free cap. Second thing, of course, I don't know, I've not done it but to my mind, what comes is you can also do a trypan blue staining. Because if you stain with the trypan blue, the epithelium side of it will not stain, but the stroma where the corrugations are there will stain.
We can use fluorescent dye also.
Fluorescein.
We keep a few sterile fluorescent ETO and keep it. That also is very useful.
Okay, great. Also, before we remove that, whenever there is free cap, the thing is keep the flap right in place on your microkeratome, because you will know the site there and you can just slide that on the surface. I think we move on with the next
just
case.
a couple of points, Himanshu. Hi.
Please, Dr. Rajesh, please go ahead. Yeah.
One thing about free cap is that if you get a free cap, it's important not to get your flap dehydrated or overhydrated. In both the situation, you will have a problem in putting the flap back. If you keep it dry, it gets dehydrated, it becomes smaller than your bed. If you overhydrate it, it will become quite thick. And then when you put your flap, you will find that it doesn't stick. It keeps moving all the time. So, in that scenario, having a post-operative displacement of the flap is quite high. With regards to suturing, Namrata made excellent points. I think one of the things that you need to do when you're suturing is that you put your flap in position, dry the edges, and wait for a couple of minutes. Let the flap stick to the underlying surface. And then when you take your bites, there is no need to hold the edge of the flap. You can take your bite with the 10-0 nylon, but take it in one go following the curve of the needle. It can be full thickness on the side of the flap, going about maybe 200 to 50 microns in the stroma. come out, take larger bite, don't take smaller bites, because you're taking superficial bites. When you tighten the suture, the chances of cheese wiring will be very high if it is fairly superficial. And don't be in a hurry to tie the knot for the first suture that you have taken first, because if you do that, you not only will you get wrinkles, sometimes that will displace the flap as well. So I think it's important you place all the sutures that you want, whether it is 2 or 3, and then once you have placed your suture, then go back and tighten the suture, but not with the kind of tension that you are used to doing in keratoplasty. These will be with minimum tension so that you don't create wrinkles and you don't pull the flap to one side. And same thing with regards of identifying, you can do all the techniques that you have described, but simply drying both the surface and observing under high magnification, you will see that the stromal side definitely will have a little bit of roughening compared to the epithelial side, which is fairly smooth. Applying dye is good, but then what happens is once you apply the dye, the flap will absorb all the dye. So then when you are trying to put it back, sometimes you may miss out other things which, when the dye becomes completely stained. So even if you have to stain, just stain one edge of the flap. Don't immerse the entire flap into a dye and make the whole thing either blue or yellow using fluorescent or trypan blue. These are the few points I wanted to add.
Thank you, Dr. Rajesh. So nice of you. We'll move on to the next case, please.
Hello, am I audible, sir?
Yeah, you're audible, Rakshita. Please go ahead.
Yes. Good evening, everyone. Today I'll be presenting a case on accommodation trouble. So we had a 33-year-old female patient who was interested in refractive surgery. She visited our center. She was teacher by profession. She was using spectacles since 10 years. She changed it a year back. She also gave history that she was on treatment for migraine since 5 to 6 years. This was the refractive status of the patient on the first visit. She was using glasses in the right eye -8 sphere and in the left eye -9 sphere, improving till 6/9 in both eyes. But on the retinoscopy, in the right eye it was -5 sphere and -1.25 cylinder at 100 degrees, and in the left eye it was -6.5. She was accepting in the right eye -5.5 with -1.25 cylinder at 100 degrees and left eye -6.5. And she was improving till 6/6 in both the eyes. So on examination, she was orthophoric, extraocular movements were normal, anterior segment was, even the posterior segment was normal, even the corneal topography was normal. Next slide, please. So we got her dilated retinoscopy done. So then in the right eye, her retinoscopy findings were -4.5 with the -0.75 cylinder at 90 degrees, and in the left eye -5.5 sphere with -0.5 cylinder at 70 degrees. And she was accepting -4.5 and -5.5 and improving till 6/6. So we went ahead and we took the detailed history retrospectively. So she revealed she was purchasing the spectacles from the optical shop every year. So she was diagnosed to have the excessive accommodation, and we advised her both eye homatropin eye drops 2% twice daily for 15 days. We called her after a week for the post-mydriatic test. So on the PMT, her retinoscopic findings were in the right eye -5 sphere and -0.75 cylinder at 100 degrees, and in the left eye -6 sphere with a -0.25 cylinder at 180 degrees. And she was accepting -5.5 and -6.5. And she was improving till 6/6. She was prescribed glasses according to the cycloplegic refraction for 1 month. She used the glasses for 1 month, and then later, after a month, after a month, she underwent both eye PRK. Post-operatively, her vision unaided in both eyes was 6/6. And she also said that her migraine symptoms had subsided after the PRK. So my questions to the panel is, which cycloplegic is preferred, and how to choose, and how long do we prescribe? And how do we actually confirm the correct refractive error? And is there any protocol that we can follow in such cases? Thank you.
Thank you, Rakshita. We will take 3 cases and then we will have discussion so that we can have discussion time. And we have 13 cases, mind you, so we have to finish on time also. So next, Shriram will present his case, and after that, Manisha should be ready, and then we'll have the discussion. Shriram, go ahead.
Good evening, everyone. Am I audible to you?
Yes, Shriram, you are audible.
Yeah, so the next slide. So I'm going to present a little interesting case. This was a 35-year-old male who had visited us post-LASIK 1 month with complaints of blurring of vision in the right eye. And on examination, he had a UCVA of both 6.6 in both the eyes. He had undergone femtosecond LASIK 1 month ago. Next slide, please. And both his anterior and posterior chamber examinations were normal. Next, please go to the next one. Yeah. Please go forward. Yeah. So then we also did an eye trace just to know, okay, is there any aberrometry that is under fault? But the point spread function of both the eyes was normal. And next slide, please. So then next. So we went ahead and also did an orthoptic evaluation just to know and look for presence of any unmasked NSBVA, and that also turned out to be normal. Next slide, please. Next. So then we started trying to understand why this patient is complaining of blur vision and also what is the reason. So we decided to dig in a little deeper. Next. And so then we revisited the patient's history, spoke to the patient at length, and that's when we realized that the patient was under a lot of stress. He constantly felt that he could not see clearly post-surgery. His history also revealed many stresses, like he had a 5 p.m. to 5 a.m. job, and this disrupted his sleep cycle, leading to insomnia. Also, he was under a lot of stress from his company people. Next slide. All this was causing him tremendous amount of stress and anxiety. However, he blamed this all on the surgery. Now, keeping all the scientific things under mind, we also thought, why can a deranged circadian rhythm or biological clock have an effect on the vision? So we did a little literature search, and we found that circadian rhythm and biological clock are interrelated. Next slide. And they can cause impairment of vision. So this is a recent article in the New England Journal of Medicine published in February, where they have shown the different effects on disrupt circadian rhythm in the body and also biologically. So panic attacks, next slide. So it also leads to visual impairment, and the panic attacks themselves result in a lot of physical changes in the body, including the eye, where they are known to cause blurring of vision and also dilatation of pupil. So we thought we'll counsel the patient, next slide, in the presence of a close family member, wherein his wife, next please, revealed that the patient was suicidal at some times, and then we knew that the patient needed professional help. Now, keeping in mind that, next slide, his fragile mental state, and we also explained him about the impact of a deranged sleep cycle and anxiety on vision. And in order to avoid the unwanted stigma and further stress, we use the term neurobiologist. Next slide. Then, having referred to him, we started him, the neurobiologist started him on anxiolytics, and post-therapy, he showed improvement in his visual symptoms and also anxiety-related symptoms. So thereby the patient was more happier, and he didn't complain of any blurring of vision after this particular counseling and therapy. Thank you.
Thank you, Shriram. And we can have now for Dr. Manisha Dwivedi with her case, and then we'll have the discussion. Dr. Manisha, please.
Good evening, everyone. Are my slides visible?
Yes, Manisha, please, everybody go ahead. If it's not visible, you're not audible, we'll tell you.
Okay, sir. Good evening, everyone. I'm going to discuss here one interesting observation of retinoscopic dilemma during routine workup of refractive surgery. Next slide, please. So here, there was a 33-year-old female which was aspiring for refractive surgery. There was a stable refraction for past 2 years for her. No history of past contact lens use. Her corneal topography was normal in both eyes. Fundus examination was normal. Next slide, please. Yeah. So during her refractive workup, in her subjective acceptance, we observed that in right eye, it was -6 sphere with -0.50 cylinder at 50 degree, correcting to 612. And in left eye, it was -4 diopter sphere with -0.50 cylinder at 20 degree. During retinoscopy, we observed that in right eye, although it is correlating with the subjective acceptance, But in left eye, in contrast to -4 diopter sphere and with -0.50 of cylinder, in retinoscopy, it was just -1. So we did OCT for this patient. In right eye, OCT scans were within normal limit, but in left eye, we noticed in transfers as well as vertical sections that there is altered macular contour. As we can see here in the OCT pictures, that the temporal part of the macula is relatively anteriorly positioned as compared to the foveal area. Next slide, please. During our post-cycloplegic refraction, again in subjective acceptance, we noted that in right eye, it was again correlating with the pre-dilatation subjective acceptance. It was -7 diopter sphere with -0.50 diopter cylinder. But in left eye, again, it was correlating with the pre-dilatation acceptance, -4 diopter sphere with -0.50 diopter cylinder. And in retinoscopy, we were observing the similar phenomenon of -1 diopter sphere, in contrast to the -4 diopter sphere of subjective acceptance. So based on OCT findings, we tried retinoscopy by changing the angle because we noted that there was a slight temporal elevation of the adjacent part of the macula. So we changed the angle of the retinoscopy temporally, and we again tried the retinoscopy, and we found that it was corresponding with the subjective acceptance. It was -3.50 diopter sphere with -0.75 diopter cylinder. Next slide, please. So this patient had both eyes compound myopic astigmatism, and in left eye, it was altered retinal contour. This patient underwent LASIK based on the subjective acceptance, and there were no post-operative refractive surprises. Next slide. Similarly, we found this in other few patients as well. So in case 2, in a similar way, subjective acceptance in right eye was -0.25 diopter sphere with -0.50 diopter cylinder, and in left eye it was -4.25 diopter sphere and with the -1.50 diopter cylinder. In retinoscopy, we noted that in right eye, the retinoscopy findings are correlating with the subjective acceptance, but in left eye, again, we noted that it is just -0.75 diopter of sphere with same amount of cylinder. Similarly, in case 3 as well, we noted the same thing. In left eye, it was -2 diopter of sphere and with -1.50 diopter of cylinder. And in retinoscopy, it was just +0.75 diopter sphere with same amount of cylinder, while right eye findings were correlating with the subjective acceptance. Next slide. So these both patients again had normal topography, normal anterior as well as fundus examination. OCT again showed the altered macular contour. So as in first case and as demonstrated in the diagram, we did the retinoscopy by changing the angle little temporally, and we found that the subjective retinoscopy findings were correlating with the subjective refraction. Both of these patients again underwent LASIK based on the subjective acceptance, and there were no post-operative surprises. So just to explain what we did here was that because of these patients were having altered macular contour, so during when we were doing retinoscopy in the primary position, it was probably hitting the adjacent elevated part of the retina. Because of that, we were finding less retinoscopic values as compared to the subjective acceptance. So we tried changing the angle a little temporally so that during retinoscopy, it was hitting the fovea, and we were finding that retinoscopy values are now corresponding with the subjective acceptance. So next slide, yeah. So in such cases of where we find that unilateral retinoscopy values are less than subjective acceptance, we should consider altered retinal contour, and OCT should be done in such patients. And by changing the retinoscopy position according to the OCT would help in such cases. And refractive surgeries can be planned based on the subjective refraction. Thank you.
Thank you, Manisha. Is Dr. Sujata around? She can discuss the case. Okay, if she's not around, I would request Dr. Rajesh Fogla if he can comment upon the cases, and then we can have discussion further. Just brief comment upon the cases, Dr. Rajesh, if you can.
No, I think what these cases have basically, demonstrated that you cannot go and do a laser treatment based on objective findings. You do subjective refraction refinement is still plays a very important role, and especially if somebody you know, is overcorrected, you can end up with a hyperopic surprise after laser refractive surgery. So I think the first case had the question was, which is the best cycloplegia to use? You know, if you have a patient who's, for me, I think I use basically cyclopentolate, and you know, we try to get that to relax the accommodation, and we are in no hurry to do a laser refractive surgery, because sometimes it may take several weeks before you can get the patient's you know, hyperaccommodated state to come down. In terms of I think I missed out the next case which was presented after that.
Next case was biological clock. He was Shriram was talking about the circadian rhythm.
Yes, but that again, I remember in between the presentation there were some issues about suicidal tendencies and, you know, altered psychosomatic behavior. So I think those kind of patients are not ideal candidates for refractive surgery at all. So if I had some patient with those kind of things, maybe I will avoid doing a laser refractive, because no matter what you do, he's never going to be satisfied, and he'll always find out some issues despite the best of refractive outcome. So, and the last case, I couldn't understand what does retinoscopy change depending on the, you know, whether I can understand axial length changing depending on which direction your you know, your probe is positioned, whether it's going to the fovea or to the adjacent part. So for me, I think a subjective refinement of the refraction that you have should be able to help us achieve, depending on how the patient is focusing, and based on what refraction that you get on repeated examination, that is what you would treat.
So it's a very interesting finding which they have presented first time. I don't think anybody has reported the altered retinal contour changing the retinoscopy. So wherever there is retinoscopy which is showing less, that's something which they have reported, especially in one eye, and it's very interesting. Dr. Sujata is here. I can ask Dr. Sujata, when would you do cyclorefraction? Which are the cases where would you want to do cyclorefraction?
Yeah, actually, I had gone through that case earlier, and the most of these patients who are requiring cyclorefraction would not be in the age group of refractive, going in for refractive surgery. But we do come across occasional patients where the cycloplegic refraction is more than the acceptance. So these are the patients who have a ciliary spasm. So what I would do is I would definitely do a cycloplegic refraction using cyclopentolate, and then wait for a week and then do a PMT. And I would go by what the PMT says. And I would really not believe in the durochrome test, because some of these patients, they keep accepting, they keep seeing green in spite of the fact that we are overcorrecting them. And the other important thing that you have to go for is, when you're doing a PMT, is just go for the lowest minus that they are comfortable with, instead of the highest minus. So if you come across a lot of discrepancy between cycloplegic refraction and your acceptance, go for the lowest one. So that will be of some use, because I have had a couple of patients who have had an overcorrection, that is went into plus after PRK. So this one I was discussing with others, and they asked me to put the patient on cycloplegic, and I had put them on HA for about 3 months, and then but the refraction did not change to beyond from +2 to it came down to 1.5. So I decided to recorrect and corrected him that 1.5, and then he landed up with a minus. So again, so this has become, it's like a vicious cycle. So when you do come across a patient who has a pseudomyopia, it's very important to decide what exactly would be the refraction, and also prefer to do a lower minus than a higher minus. Then you can always get away by retreating if the patient has a residual myopia.
Thank you. So the cases which please go ahead. Please.
For that, to avoid this kind of a problem, if patient has this accommodative spasm resulting in increased myopia, and sometimes these patients already have been visiting other doctors, and progressively they have been given glasses which are overcorrecting them. And because they are using these glasses, they somehow become comfortable to these glasses. So these patients, what we do is we do a cycloplegic refraction, but then we give them a undercorrected, what exactly the refraction they should be wearing. Initially, they are not happy with it, but we ask them to wear that. And only once they become comfortable with those glasses, then we embark on doing a laser refractive surgery. Otherwise, even if you do the laser refractive surgery, they accommodate and they come back to you unhappy, saying that the refractive surgery is not working. And if they push you, then you are pushed into doing a early enhancement, and you end up with, going back and forth the metropia.
In fact, that's exactly what even I was going to comment on the case. They gave 15 days of hometropine and then 15 days gap, but the patient would have gone back to his old glasses. So ideally, you should either give
they give the new glasses. That's what
they gave a new
said.
glass. Okay.
They gave. So the cases which I would prefer, I would rather say I would definitely do cycloplegic refraction, all the hyperopes, all the myopic, simple myopic astigmatism, low refractive error, all the retreatments or all those who have undergone LASIK earlier, all those where my objective and subjective has a huge difference, and all those who have squint, I would definitely do a cycloplegic refraction. That brings Dr. Namrata to you.
Yeah, I just wanted to know, Himanshu, for my own understanding and my awareness, I thought everybody does cycloplegic refraction for all patients prior to LASIK surgery. I mean,
I personally don't do for all the cases of myopia where my objective subjective. I do dilated refraction every case, but I personally don't do cycloplegic refraction for every myopes. But I wouldn't say that that's the best way. That's my way.
Oh, it was a revelation to me right now, because I used to think that everybody does it, because we do cycloplegic refraction under hometropine for everybody who comes for a refractive surgery, irrespective of, whatever. So irrespective of the refractive error or the kind of refractive error. So I just wanted to understand whether people are doing it or not. And
dilated refraction, but not cycloplegic, unless, like what Himanshu said, that it's unless it's a hyperope or a patient who has discrepancy pre and post dilatation acceptance. And otherwise, I don't think any reason for to do this, because most of them are above the age of 22. So
yeah, so we've been doing for all our patients for all these years that we've been doing refractive surgery, and I think several of the things were very nicely brought about, like duochrome test should be done, cross cylinder should be done. Nikhil wrote that, and I think angle kappa should be evaluated, eye trace should be done, and now to this armamentarium, another thing has been added, that probably macular OCT should also be done, because I have not come across a case like this as trying to look at the literature. I don't think there's anything reported also like this.
I have a doubt. How can
Rajesh
retinal thickness
said,
cause 4 diopters of refractive shift?
No, it's not retinal thickness, Rishi. It's the contour. It's not retinal thickness.
So the instant reaction was the same as Rajesh Fogla's, that why should that alter refraction, in Rishi Swaroop's that, why should that alter refraction? But that is something which should also be explored, I think. I mean, maybe more logically and more.
So I open to all the panelists that what are your views? When would you do atropinization? Do you do atropinization any case? And when would you do atropinization? How anybody wants to take up that panelist, please?
So atropinization, you mean under atropine ointment?
Whatever you use, atropine drops, ointment. When would you use atropine in these cases? Do you use atropine at all or no?
I've never used.
I can't remember using atropine ever, but we use hometropine for everybody.
The max we usually cycloventilator, not beyond that in this age group, as far as I remember. Maybe some other people may be using, if they can tell.
I think if you
mostly
see
tropicamide
among the objective and subjective, or you find that patient has numerous prescriptions prescribed at various frequent intervals, I think that is the case where you have to consider doing a cycloplegic and getting your own. And those are the patients I think they need multiple visits before you go ahead and do a laser refractive surgery. Because if somebody has accommodative spasm, I think it takes a longer time for them to come back to normal. Otherwise, post-operatively, they do have issues with their visual acuity.
Also,
I think that's a very valid point. Please go.
Also, patients with phobias, esophoria, I think it's better to do an atropine refraction, because we really don't know what is the cause for the chorea. It could be an hyperaccommodative status. So this is normally done by our optometrist. When there is an mesophoria and the patient is coming for refractive surgery, they prefer to put a cyclopentolate is actually the first choice, because you don't want to atropinize the patient and keep him away from his jaw for more than a week. So cyclopentolate, some sort of cycloplegic definitely is warranted. Patient with chorea.
So only place where I think of atropinization is my hyperopes post-operatively if they go into spasm, which they usually do, and there it's very difficult to remove that, and there you may need atropinization. But again, as we were discussing pre-op, I don't think that's as relevant. I think from here on, I hand over the proceeding.
Can I just add one last point? If just I think in the last 2-3 months, even in our general OPD, there's a huge rise in accommodative spasm, not like in kids, but at least 0.5 to 1 diopters with the COVID. And I agree with Namrata ma'am that we have been doing cycloplegic refraction for every LASIK. And I would say at least in 1 in 40, we have changed the refraction with a huge difference in cyclo and dry. So I would strongly believe everyone would require, and as you said, smaller myopes. And now with COVID, last 2-3 months, we have had a lot of changes in the spasms, and our binocular vision therapy has changed. So I think with this year, I think we should be a little more careful because of the excessive digital work.
I agree with you, but I don't think it's a preferred practice across the world that every refractive surgery must be cyclopledged. But point well taken. It's something we should look at our outcomes. I'll hand over the proceeding to my co-host, Dr. Chintan, and she can take it forward.
Thank you, Dr. Himanshu, and a very good evening to all. So since the next 4 cases are kind of relating to infections and inflammations, and we know that sometimes we confuse between the two, we've decided that we'll take the next 4 together and then go on with the discussions. So can we have the next presentation, please?
Hey, everyone. Can I have my next slide, please? Yeah, so this was a case of a patient who presented for refractive surgery with a normal refractive error, standard LASIK. The patient had myopia. First post-operative day, the patient was doing well with an uncorrected visual acuity of 6/6. I sent him on the usual treatment of steroids, antibiotics, and lubricants, and he calls up at about 3 p.m. complaining of pain. I called him into the clinic, and to my horror, I saw this kind of picture where there was this infiltrate which had rapidly progressed. Cellularity was also starting along this infiltrate. So in my horror and fear, I stopped the steroids. I thought this was an infection and started topical fortified vancomycin and amikacin eye drops. There was a little cellularity starting in the other eye also at this point that I noticed. This was in the right eye, this picture, the clinical picture. Next slide, please. So the next day, to further enhance my fear and trepidation, what I saw was the left eye was now involved, and it showed a worse infiltrate in the right eye. And there was an increase in the density on the infiltrate in the right eye. Next slide, please. So at this point, really panic had set in completely. I got a scraping done. It showed gram-positive bacilli, which were inconclusive. We stepped up the antibiotics. We started reconstituted colistin as well. But looked at the photos again, took a few opinions, and thought that it may be immune-mediated. So under cover of antibiotics, we started the topical steroids as well as systemic steroids for this patient. Next slide, please. So it gradually got better, and this was a picture on day 15. As you can see, the infiltrate has healed with a given way to a scarring, and the patient's visual acuity also improved gradually to an uncorrected visual acuity of 6/6 in both eyes. Next slide, please. So with this in mind, we made a diagnosis of peripheral infiltrative keratitis. There are a few reports of this. It's been reported post PRK as well as post C3R. One of the etiologies suggested was NSAIDs affecting the lipoxygenase pathway, as well as the trapping of tear film antigens by the bandage contact lens. However, this patient, it was different because we hadn't placed a BCL following the procedure. So in this kind of patient, considering the patient was already on steroids, and normally steroids prevent a kind of
infiltrative or immune-mediated keratitis. I just wanted to throw it open to the panel regarding how would you have managed this case differently, and was there anything that we could have done differently in this particular case? Thank you.
Thank you, Dr. Rushad. And the next case is fairly similar, so we'll take that as well.
Good evening, everyone. I'll be presenting a case almost similar, the radiating ring of fire post-PRK keratitis. A 24 years old male who had undergone photorefractive keratectomy 4 days back elsewhere presented to us with complaints of blurring of vision, watering, pain, photophobia, unable to open both eyes, in a very anxious state, no history of any systemic illness or any known allergy, no significant family history. Next. He was on a cocktail therapy of all these antibiotics, as he had already shown 2-3 surgeons before coming to us. On examination, his best corrected visual acuity was 6/360 in right eye and 6/180 in the left eye. Slit lamp examination showed a juxtalimbal ring of infiltrate, creamy white in color, almost 360 degrees in the right eye and 180 degrees in the left eye. There was surrounding edema and cellular reaction. We can also see the collagenolysis in the peripheral area. There was a central epithelial defect. One thing noteworthy was there was no hypopion, or the AC was not that, AC reaction was minimal. So we went ahead with the corneal scrapings and we got no organism in it. Cultures were taken. Next, please. So we came to a diagnosis of post-PRK keratitis. We were not sure whether infective or toxic. We decided to shun off all the antibiotics and keep him only on chlorocol, which is surface friendly, other symptomatic treatment, and doxy to take care of the collagenolysis. Next, please. Next day, that is second day of presentation, he was symptomatically better. Next. Next, please. He was symptomatically better. The left eye, the infiltrate had gone down, the ED was reduced. Right eye was also, the ED was better, but there was a consolidated infiltrate. So we re-scraped the patient as we couldn't rule out infection. But again, we got no organism, no growth in the previous scrapings. According to the infiltrate, the limbal near the limbus PUK type picture, we decided to give a shot of loteprednol for 1 day and the patient was better. So we gave a whole course of Predford. Next, please. And 10 days later, as we can see, there's a clear cornea and the ED has resolved. Next, please. As we can compare with the old picture, it has beautifully healed, resolved, infiltrate. So this is a magic of steroids, I suppose. Next. So final diagnosis of post-PRK sterile keratitis was made. And we can see as the case progressed. Next. Day 1, 1 week, 10 days and 1 month, how the steroids have acted as a fire extinguisher in our case, improving the vision from 6/360 to 6/6. Next, please. So my questions to the panelists or discussion points are: first, post-op day infiltrate. Is it always a nightmare? How to rule out infective cause? What would be the probable cause of sterile keratitis? BCL, NSAIDs, or MIBA, or something else? Thank you.
Thanks, Indrojit. I think those are all the questions that we are going to be addressing after the next 2 cases also. So can we have the next case by Dr. Pratima? That is the acanthamoeba post-LASIK flap infiltration.
Hello, everyone. Am I audible?
Yes, you are.
Am I audible? Yeah. So good evening to everyone. Yes.
Please carry on, Pratima.
Yeah. So good evening, everyone. Today I'm going to present a case on post-LASIK flap infiltration by acanthamoeba. So next slide. A 24-year-old female who underwent microkeratome-assisted LASIK elsewhere. Please, next, please. Just the animation part, please. Hello. Yeah. So a 24-year-old female who underwent microtome-assisted LASIK elsewhere 3 months ago for myopia of about 4 diopters presented with a painful decrease of vision in left eye. At presentation, her visual acuity was counting fingers close to face. She was diagnosed as having nocardia keratitis elsewhere and was on fortified amikacin hourly, moxifloxacin 2 hourly, and hometropin twice a day. So here we can see that on slit lamp examination, she had an infiltrate of about 8.2 by 6.4 mm, which was anterior to mid-stromal, diffuse, and here we can see that LASIK flap is present and there is some necrotic area over the flap. So next slide. At this point of time, a differential flap infiltration with organisms like Acanthamoeba, HSV, nocardia, atypical mycobacteria, fungus, bacteria, and also diffuse lamellar keratitis. Next, please. Next, please. So to establish a microbiological diagnosis, we lifted the LASIK flap and scraping was done from the stromal bed. The unsalvageable part of the flap was amputated. Next, please. Gram staining was done. In gram stain, we could see that there were hexagonal double-walled cysts of Acanthamoeba, and on in 10% KOH and 1% calico flower white stain, we could see fluorescent Acanthamoeba cysts. Excised LASIK flap also showed double-walled cysts of Acanthamoeba. Next. Numerous cysts could be identified on NNA culture of the excised flap. Next. Based on this microbiological evidence, we changed the treatment to PHMB 0.02% hourly, chlorhexidine 0.02% hourly, and atropine TID. After 1 month of treatment, observing the signs of resolving infection with deep vessels, topical 1% prednisolone acetate was added every 3 hours, and then gradual tapering was done. Patient was followed up. Keratitis resolved in about 6 months, and leading to scar formation. Next, please. So at 1 year of follow-up, her best corrected visual acuity was 20/25. Next. So from this case, it is important to note that in post-LASIK flap infection, clinical features are not similar to that with non-LASIK flap non-LASIK microbial keratitis. Typical clinical features like those seen in Acanthamoeba keratitis, like ring infiltration and keratoneuritis, are usually not seen with post-LASIK flap infiltration. Due to this, before starting steroids, microbiological confirmation is important, which can be established by lifting the flap and scraping from the stromal bed. Amputation of flap can also be done if it is necrotic and the non-salvageable part should be removed. This is basically not a poor prognostic factor, so we should not hesitate in flap amputation if it is necessary. Even confocal microscopy can help in diagnosis of Acanthamoeba keratitis, though it was not done in our case. Thank you.
Thank you, Pratibha. And the next case also by Dr. Namrata we'll take. This is a little different from the other 3 cases, but then we will discuss them all together.
So I'm going to be talking about a case of post-PRK inflammation with pigment dispersion and refractory glaucoma. Next slide, please. So this was a 25-year-old male who came to opine about refractive surgery, compound myopic astigmatism, refraction is mentioned. The slit lamp examination, dilated fundoscopy, everything was unremarkable, except that there was a scar in the left eye at 7 o'clock position of 3x2 millimeter size. The pentacam corresponded with the clinical examination, and in view of this scar, we planned a PRK procedure for this case. Animation, please. So this was the pentacam of the right eye, pre-normal, and of the left eye. Animation, please. So this corresponded with the clinical examination. We can see an elevation where the scar is. Next slide, please. So we go in for the routine PRK procedure, except that I want to highlight that we use 20% alcohol to expedite the epithelial debridement, and we use 0.02% mitomycin application, 10 seconds per diopter, 30 seconds was used in this case. What we do is that we put a bandage contact lens soaked in preservative-free moxifloxacin, which acts as a depot. operative medication is the routine lubricants, moxifloxacin antibiotic, followed by BCL removal when the epithelium heals, and then we start the steroids. This patient had an uneventful course until day 14. Next slide, please. After this, we notice, and from day 14 onwards, this patient started presenting with pain, photophobia, congestion, always left eye more than the right eye. So this led us to step up the steroids, and consequently, the next finding was that the patient's IOP started peaking, again the left eye more than the right eye. We added every anti-glaucoma in the book that was available, timolol, combinations of brinzolamide and brimonidine, tablet acetazolamide, but the patient was just not improving. In fact, the right eye now developed an increase in IOP. Now we ordered systemic investigations. Next slide, please. So the only important finding that we had was, or the positive finding was, that the patient was IgG positive for CMV and varicella zoster virus, again IgG. And in view of the current times, we also tested the patient for COVID, which was negative. Next slide, please. So as we say, the patient had a further downhill course. The pressures peaked to 52. There was a near total epithelial defect. We had to put a BCL back on. And we also gave mannitol infusion, but that it led to only a temporary spite, and only on that day of 7 to 10 millimeters mercury. After this, the patient again spiked up, and now the right eye also developed the signs and symptoms. And then we further had to send the patient for a second opinion to PGI Chandigarh when we thought we could not contain the situation. Next slide, please. So these are the pictures. The pupil hair is pharmacologically dilated. We can see the amount of pigments that were there on the anterior lens caps. Now, this was a true nightmare, and also the IOPs that we were seeing. So the AC reaction was primarily a pigment of pigmentary nature. There was no inflammatory cells and nil or minimal keratic precipitates. Next animation. So on retroillumination, this is the picture that we found. I'm not sure. I would like the experts to comment if this could be called a transillumination defect. Next animation. So this was the nature of the uveal inflammation that the patient was having. Minimal or no keratic precipitates, primarily pigment as a form of AC reaction. Next slide, please. So the working diagnosis of bilateral acute depigmentation of iris was made. However, our case seems to be more in the favor of bilateral acute iris transillumination, because this is a more severe variety of BADI, in which the glaucoma is more persistent and resistant to AGMs, and also the amount of pigment that was dispersed. Also, I would like to mention this is the fourth kind of case that we've got in the year 2020. And all these patients have had glaucoma to carry forward with, and they have healed with dilated and atonic pupils, which have been very poorly responsive to light. In view of the current literature that is there, since oral moxifloxacin has been associated with BADI or BAIT, we substituted that for chloramphenicol. Also started oral steroids empirically. Valcyclovir was started, ganciclovir gel, and mannitol intravenous infusions were started just to tide over the acute crisis, to the order that we had to give it twice a day, sometimes for at least 10 days. And currently the patient was maintaining a normal pressure till up till yesterday. Again, we saw a surge of 26 millimeters in the left eye. So my question to the panelists are that is this a case of BADI or the severe variety of it BAIT, if we can call what I saw or what I mentioned as a transillumination defect, because the features are more aggressive as they are in BAIT. Pigment dispersion glaucoma was the next diagnosis, but again, it does not have such an acute history and presentation, or it was of a viral etiology. Well, we're still in a puzzle, but the patient is doing well, but again, the spike has come. So I think I'd like the panelists to comment now.
Thank you, Namrata. And so we'll just go on to the discussion for this. Dr. Bhaskar, would you like to comment on the cases first?
Yeah, good evening, everyone. All the four cases were quite well managed, quite challenging. So I'll start off with the first two cases, which are similar with respect to a peripheral sterile infiltrate as such. Now, one was in LASIK, one was in PRK. The only thing is I would just want to know whether for the LASIK case, he did mention about, we do know that you have the role of NSAIDs as far as causing a sterile keratitis is concerned, because it affects the cyclooxygenase pathway preferentially, and because the lipoxygenase gets released, you still have leukotriene which accumulates and causes the reaction. The other other one is a tight contact lens fitting because of hypoxia, which can cause a change. And the third one would be a blepharitis, which does induce a marginal catarrhal ulcer like we normally see. Primarily, these are the three reasons that we would look at in patients with a sterile infection, sterile keratitis. But we would definitely want to rule out an infection when we see a patient with a refractive surgery who comes with this presentation. Generally, they come within the first day to maybe about 3 to 4 days time is the general presentation time. The first patient, LASIK patient, he did mention about BCL. So I wanted to be sure whether a bandage lens was used in that case or not. Because
I think he mentioned not.
I mentioned at the end that I hadn't used a BCL in that.
So if the BCL was not used and if it was a femtolasic procedure, not a microkeratome based procedure, then the probability of infection and the appearance of the lesion probably still would probably think more of an inflammatory cause rather than an infective cause. So to that extent, colistin was probably an overkill, but I can understand when you see a LASIK patient jumping in at in the afternoon with pain and discomfort and that kind of a lesion, you will become a little bit anxious.
Would there be any specific pointers you would like to give us how to differentiate between infection and
the ring-like appearance, which is probably generally at either just beyond the flap margin or just involving the flap margin as far as the LASIK is concerned, or similarly it is closer to the debrided edge if your PRK is concerned. That's the area where you probably have the maximum accumulation of the antigenic material and the tears, and you have an exposed epithelium there, and it kind of triggers the change. The other thing would be the absence of an epithelial defect as far as the first patient LASIK flap was concerned. So like in a sterile infiltrate, you're looking at generally pain or comfort is slightly, I mean, it's not as uncomfortable as an infective ulcer. Generally, the epithelium might be intact, even though you might have smaller defects to go around with. So in that case, when you have two lesions which are kind of coalescing to form a ring kind of a thing, closer to the limbus, without an epithelial defect on top, I would probably think of an immune mediated rather than an infective. But with such a large thing, maybe if it doesn't respond in a day, I would definitely consider a scraping. As far as the second one is concerned, it got confused by the magnitude of topical antibiotics that the patient was on. So if you look at the picture, the first case, the eye looked a little bit more quieter, whereas the second case, the PRK, the eye was looking a lot red, almost as if there is an active infection. That was primarily more of a toxic medicamentosa because the patient was put on so many medications. Again, if you are seeing the patient as the first one with a contact lens on in a PRK, you are probably a little bit more worried about an infection in a PRK patient because you've put a contact lens, and that would probably with an debrided epithelial surface where you're more worried about an infection as such. So if you see a patient, then apart from the scraping, the contact lens will also need to be sent for culture as such. And those two dot-like infiltrates which kind of came at day 2, once they stopped all the medications, are very classical, like your marginal lead-related infiltrates that you see. And again, in the second case, the anterior chamber reaction, everything was much lesser. So it kind of points towards an immune etiology.
AC reaction is, I think, a very important thing also, which helps us to differentiate. Do we have Dr. Bhupesh here for his comments? I think not. Dr. Rishi, I'll come to you then.
Bhupesh is here.
Okay, yes, Dr. Bhupesh, please.
Hi.
Your comments about the cases, Dr. Bhupesh?
Yeah, so I think thanks for nicely managed cases, and those are very difficult cases to show. And so I believe the first important thing is in post-LASIK or post-PRK infectious keratitis is to rule out the infection by doing corneal scraping rather than thinking in line of empirical treatment and thinking in line of managing empirically. So as I think managed by all the presenters, they should, even if the smallest infiltrate also, I think it's a good idea to lift the flap and scrape it and get complete microbiological workup. The reasons are very pretty obvious, that because usually in the normal cornea, whatever the clinical picture you are seeing of a particular organism, it is not as obvious as in post-LASIK cornea. You will not see a classical presentation of a similar organism in post-LASIK versus in the normal cornea. So it's always good to establish a microbiological diagnosis. Number 2 is the the susceptibility you should know, because many a times this is caused by a resistant organism as well. So that is also very important. So I believe the treatment guide should be guided by microbiological, and also should not be empirical, and should be done by doing lifting the flap, and also establish a microbiological diagnosis, considering the how you differentiate between the infective versus, as Dr. Bhaskar covered very nicely. But I believe one thing is very important, that if they are presenting within hours, or within, you can say, 1 to 2 days, and diffuse and not very symptomatic without anti chamber reaction, and you're not able to find out any particular localized reaction, you can think of in terms of non-infective etiology. If you're thinking in lives of localized infiltrate, and particularly AC reaction or hypopion, think in terms of infective etiology, and scrape it and establish microbiological diagnosis.
Thank you. So, Dr. Rishi, I'll come to you with that. What would your indications be for lifting the flap?
So, the obvious indication is if it's a grade 2 diffuse lamellar keratitis, which is not responding to steroid therapy, grade 2 onwards, you must lift the flap and wash the interface. And of course, any case like Bhupesh mentioned, where you see an infiltrate in the interface, you certainly want to rule out microbial keratitis, and you must lift the flap and scrape. And also just washing that, even if it's sterile, washing that itself will help. The other indications are if you have gross flap striae, you'd want to kind of reoppose the flap in a proper way, so you must relift. Foreign bodies, if you've left a big nest of epithelial cells in the interface, it's probably a good idea to just take it off, because sometimes they can proliferate, especially if they're central, and they can create a problem. I guess that's essentially the main indications to relift the flap.
I think we've covered that. A little unrelated to these cases, but Dr. Bhaskar, so sometimes you have these cases where you have the patient has had adenoviral conjunctivitis and they have these SEIs and the scars of the SEIs. So what is your preference for that in these procedures, and have you seen increased inflammation with these cases?
In the few that I have done, I have not seen anything different as compared to what we would do in a routine LASIK as such. If these scars are more, I would probably go for a trans PRK or for an epiLASIK kind of a thing. So at least the scars also get ablated. If the only thing is, if you're going to be doing a microkeratome based LASIK, it's probably okay. If you're doing a femto LASIK, you need to know the depth of the scar, because there is a small possibility of a vertical gas breakthrough if the scars are a little bit deeper. So you need to clearly assess the depth of the scar and then plan your depth of your femtolesic flap if you're going to be doing that. There are isolated case reports of recurrence of adenoviral keratitis post a couple of months later. But then we are not sure whether it's related to the laser itself, or it was just a recurrence which happened because, again, for a short period of time, the patients were on topical steroids. So whether it was a steroid withdrawal again at that point of time. But I've not had any DLK kind of a reaction or significantly inflammatory reaction with PRK or LASIK in adenoviral scars.
So would you recommend the immune modulators or topical immune modulators in these cases, let's say empirically, after doing a PRK or a LASIK?
I would probably not look at, unless there is an indication for a topical immunomodulator, like there's already a little bit of dryness because of the previous conjunctivitis related issue, I would probably put a topical immunomodulator. Otherwise, probably no. The only thing is sometimes the scars can cause a little bit of an irregular astigmatism. So if you're doing a trans PRK or you're doing a PTK to remove the scars, that because the ablation over the scars is going to be slightly different as compared to the ablation over a normal cornea. So that's something that you need to keep your patients primed.
I think that's something very important. And then coming to the last case, which was, I think, a little different but very interesting. So this, as Namrata mentioned, was diagnosed as a case of Bardi. So Dr. Bhupesh, do you have any comments about that?
Yeah, I have not seen this type of presentation before, so maybe I am not able to comment like that.
Yes, it's a little. Actually, I have a little bit of background for this case because, as Namrata mentioned, it was referred to PGI and it was referred to a glaucoma people. So we had a look at that. And it's been shown that what was mentioned as the bilateral acute depigmentation of the iris or the bilateral acute iris transillumination defects. And that's the final diagnosis which was made earlier. A viral keratitis, a viral keratouveitis would be a differential diagnosis because the patient had those pigments, but no cells or keratic precipitates in fact. And in fact, very interestingly, there's a series from Narayan Nitrale itself, Dr. Himanshu. I was going through literature today, and Dr. Padma Malini has published a series of 22 patients of body where the pigment release was seen in patients who were exposed to either systemic moxifloxacin or topical moxifloxacin or had a history of respiratory viral diseases. And so like Nimrita mentioned in her case, they had been using, and she's mentioned that they had 4 cases in 2020. The probable etiology could be the BCL, which was soaked in moxifloxacin. So providing a prolonged exposure of moxifloxacin, which we are routinely also, I mean, we are using topical moxifloxacin, but a BCL soaked in moxifloxacin could have provided a longer duration of exposure. And that's probably, if you've been seeing repeatedly, one of the causes. Otherwise, the viral etiology cannot be ruled out, but that's usually not the anterior chamber like HSV or VZV. It's the upper respiratory infections which have been kind of blamed for that.
I've seen a similar reaction after cataract surgery where intracameral moxifloxacin was used. And
yes, that's been reported
yes,
as well.
yes.
A case of intracameral moxifloxacin leading to bilateral this extreme depigmentation and raised pressures.
My point is, if it is toxic related, if it's viral, if it is something which is related to the treatment which was given intraoperatively or immediate post-operatively, does it actually start at 14 days, 20 days, such late? I mean, or we would have missed it earlier, or how does it go? Chintan, if you had read about this thing and if you...
Yes, so some of the cases have been presenting late. It's because one of the theories is that the iris melanocytes, the fluoroquinolones have an increased sensitivity for binding to those. And as they bind and after it reaches a threshold level, that's when this could present. And so this has been presenting late. And like I think Nimrita also mentioned that the patient was doing fine for a while and then has started having a recurrence. So recurrences have been reported in this if steroids are tapered too soon, and some patients may even go on up to 14 months, 2 to 14 months before the recurrence subsides.
If I could just ask, was a PCR done from the aqueous tap for CMV, VZV, HZV?
No. So in our center, this facility is not available. And also the fact that, it was a refractive surgery patient and the patient was too apprehensive, and so were we. In fact, we only tried one mannitol infusion in which the pressures came down, but, to make it sort of a way of life for 10 days for that patient, we had to literally take the approach and, the yes from a higher institute probably. But I think over there also it was not done. If I would just like to add to the literature, because it's been such an intriguing case series, I took a lot of literature review. There have been case reports of bait and buddy. I'm going to just bad eye, if I can just use these terms. But bait is more of aggressive, and in fact it is known to cause glaucoma refractory to AGMs. And interestingly, in the first case series that was presented was 26 cases. There's this Turkish group that has made this publication, but they more so have had just spontaneous occurrence of these, and they have been middle-aged women. And also, they also had 2 serological markers positive, which was IgG positive for CMV and VZV. Very traditionally, I was just so surprised to see that there were only 2 positive findings in our cases also. So how there has been some correlation, but the patient did not agree to getting an AC tap or going back to the OT, because giving him a mannitol itself was something too much. What I wanted to ask was that the picture that I showed, if we can just have that picture again, can that be called a transillumination defect, or is it just, the dilated pupil or something like that? If you can have that picture again, because initially the classification of
it was transillumination in a couple of areas where it's a intraocular surgery done as surface surgery. You still would call it a transillumination.
As small as that as well.
Yeah, I mean, it is still a transillumination, right? Because many times we come across transilluminations which are zoster related, which can be really small also. So I really don't think we can not call it transillumination, but I mean, it's really interesting. You can have a look at that. Was it always one brand of moxifloxacin in use? So is that something which can be related to the vehicle or something which is there in that particular thing? Because the moxifloxacin usage is so rampant in intraocular surgeries that maybe we are missing out on all these things.
So always, if I'm allowed to say the term, we always use Vigamox, the preservative-free moxifloxacin as they brand it out, and and it's been a decade-long practice. Like, I am new into practice, but my father-in-law has been doing it for a decade. That moxifloxacin dipped BCL has been used. But why would it happen in 2020, and why these cluster of cases came? That is why we even got the COVID antibodies and antigen testing for everybody. But again, they came out negative. So again, now it's the second wave that has come for this patient, and the other the three patients have also healed with dilated atonic pupils. There's been a sphincter paralysis. So I'm going to call back those patients now and look if they had some significant transillumination defects. I'm working on that as well, because everything falls in place for us. The serologies are matching, and in terms of the case reports that have been there, are cases very similar. But topical moxifloxacin has hardly been exactly.
I think this bandage contact lens, which is soaked, is probably delivering a much higher dosage of moxifloxacin than you would like.
Yeah, sorry. We put, I think, 2 to 3 drops. I mean, I wouldn't be very religious about it. I wouldn't like to say it more than I know, but 2 to 3 drops we put it, but we thought that probably it was acting like a depot, that it was slowly releasing the drug. But again, why after 14 days? And interestingly, this person's sister has also got operated with us and gotten a PRK. So it was not even a familial thing. So they had a confidence in us very high, that a patient, another sibling, like a blood relation, it's not even a cousin, real sister got operated, she was absolutely okay. But why this person would have? And if that scar, if it was probably some viral etiology or something which is not giving a history of, if that could be, I don't know. But again, both the eyes got involved eventually, and this pigment dispersion was too much. It was literally like an iris inside an iris.
Systemic moxifloxacin has been more associated because they say that the clearance in phakic eyes is much less than topical moxifloxacin. Even intravitreal moxifloxacin tends to clear faster as compared to systemic, where it's equal between the anterior and the posterior segment, and the clearance is slow. But there's no definite 100% it can't be attributed to moxifloxacin, but that could be a factor.
Yes, it's not frequently reported in literature, but I have received over the past several years a lot of well-established refractive surgeons, not novice surgeons, who have had these kind of complications, both following microkeratom LASIK, femto LASIK, and PRK, where they have reported that the patient was okay for the first 2 weeks, and then the patient comes back with a decrease in vision, raised IOP, not responding to medication. And finally, with the raised IOP persisting for some time, the patients tend to develop this fixed dilated pupil, possibly from the raised IOP having an impact on the sphincter muscle, the iris sphincter, and then it stops acting. And the pigment dispersion is one of the typical features seen in all these cases. So I think the first thing that people fear in refractive surgery is they think that there is some infection, and you quickly step up the topical antibiotics, sometimes to 1 hourly or 2 hourly, just to rule out. And also the other tendency is to step up the steroids. You think that okay, you're reducing the steroids, you're getting symptoms, you step up the steroids. Both are counterproductive. The stepping up of steroids also, if the patient is a steroid responder, you will have the IOP becoming worse. And the pigment release will not show an immediate impact on the IOP, because it takes time for the trabecular meshwork to get clogged up. And once it is physically clogged up, no matter what medication you give, besides trying to reduce the production of aqueous, these patients don't really respond very well to anti-glaucoma medications. So I think this is something I think you should document it well. And if you have a good number of cases, you should write it up and publish it, because that will be of great help to other people, facing a similar problem. And I think go easy on the topical antibiotics, bandage contact lens soaked in,
We stopped doing that after that, and we've shifted.
Yeah, and also applying alcohol to the surface to debride epithelium, that already kills more keratocytes than debridement. So I think that also alters the penetration of moxifloxacin into the anterior chamber. So I think you have removed the Bowman's layer epithelium. So with the epithelium on, the moxifloxacin penetration is very good. Now in your scenario with the epithelium, Bowman's membrane, everything missing, you may be delivering a much higher dose of antibiotic into the anterior chamber. It will not happen in all individuals, but certain individuals predisposed to an abnormal reaction to moxifloxacin resulting in pigment dispersion will come and present to you in this way. And very well documented is that the amazing amount of pigment that you had on the anterior lens capsule. Okay, please, I would recommend that. IGO has a journal of case report. They have just started. And if you have good documentation with those photographs, please write it up and publish it. I'm sure it will be of great resource to all refractive surgeons worldwide.
Thank you so much. I surely do.
Thank you, Dr. Fogler. And I think with that interesting discussion, we'll now move on to the next session, and I hand it over to Dr. Himanshu.
Thank you, Chintan. And we'll have the next presentation, please. And Dr. Rishi should be there. Oh, he's there, right? Thank you. Okay, Krati, go ahead, please.
Good evening, everyone. At the outset, I would like to thank Kerackonnect for giving me this opportunity and making me a part of it.
You don't need to thank anybody. You all deserve. Please don't thank. Go ahead and with the presentation. Please go.
Are we speaking on crying muscles? Next slide, please. So my case is a 22-year-old male who visited us with complaints of blurring of vision in his right eye since the last 9 months. And he gave us a history that he underwent PRK surgery 9 months back for the refractive error correction of -3 diopter sphere in both his eyes. So on examination, his uncorrected visual acuity was 6/9 parts in the right eye. And the best corrected visual acuity was 6/6 parts with a refraction of -0.25 diopter sphere and -0.75 diopter cylinder at 90 degrees. So on slit lamp examination, we found that there was a presence of a central irregular scar in the visual axis. The rest of the anterior and posterior segment examination in the right eye was within normal limit. The topography, that is the sagittal map and the cirrus topographer, showed that there was a very small central area of flattening with surrounding area of steepening. The next slide, please. So we did a detailed case study in this particular case. Now, since the patient's quantity of vision was good because his best corrected visual acuity was 6/6 parts, we went ahead and did an eye trace for this patient, and we found that the quality of vision was quite poor, which is evident on the simulated vision pattern that is seen from the eye trace aberrometer. So we thought maybe because of the centrally small clear zone, the patient is having a good quantity of vision, but the surrounding scarring is contributing to the poor quality of vision. Also, the Zernike profile showed increase in the higher order aberrations such as the trefoil and the SA. The next slide, please. The animations, please. So the conventional treatment option in this particular case would be the phototherapeutic keratectomy, but it may lead to excessive tissue ablation and hyperopic shift. Lamellar keratoplasty, again, would not be a good choice in this particular patient since his best corrected visual acuity was 6/6 parts, and we don't want him to load him with transplant-related complications. So how do we manage this case? Next slide, please. So our two options is large zone phototherapeutic keratectomy, the animation, please. But as I said, it would, the animations, please. As I said, it would lead to further flattening and the hyperopic shift. The animation, please. Animations once again. So we decided to do a small zone PTK of 4 mm followed by a topography guided PRK for only the higher order aberration treatment. This will lead to a better regularization of the cornea. The next slide, please. This treatment was planned on the Schwinn Tamaris customized treatment platform using the depth minimization profile, and the trefoil and the spherical aberrations were treated. The laser pattern is demonstrated on the right side, and intraoperative mitomycin C was also used. A zone of 4 mm was selected. The next slide, please. Post-operatively, the slit lamp examination shows that the scar has disappeared. The patient's visual acuity has improved to plano 6/9. There is regularization of the cornea on the topography. There was also improvement on the visual quality and also significant decrease in the higher order aberrations such as the trefoil, coma, and the spherical aberration. Next slide, please. But since the patient was not improving to 20/20, we decided that we'll also do a orthoptic examination for this particular patient, and we found that he had convergence insufficiency, and following office and home-based exercises, the patient's fraction and uncorrected visual acuity improved to plano 6/6. Next slide, please. So take-home points here would be customized topography-guided PRK helps in better regularization of cornea, particularly in irregular scars. An orthoptic evaluation should be considered in patients with suboptimal visual outcome post-refractive correction with no obvious discernible cause. Thank you.
Thank you. And can we have Dr. Deepti's case, please?
Yeah. So hello, everyone. So in this presentation, I'll tell something about this technique that we've developed. Can you go ahead? So this was a 27-year-old male who had a very, very keen interest to get a refractive surgery. And like many of the hyperopes, he had a very shallow anterior chamber of 2.75. Now his refraction was plus 7.75 and of a sphere and plus 2.5 cylinder at 110 axis. So we know this is higher than what most of the LASIK machines would do. What we use is a Wavelight Allegretto platform. So 6 plus is what is maximum. And with the shallow ACs, they're not amendable for implantable colamer lenses. So we have quite a few patients in this series where you have these shallow ACs and high power and extremely motivated patients. And we tried to do something different. If you go ahead. So we do this sequential double excimer laser treatment. So we plan 2 treatments, treatment 1 and treatment 2. So treatment 1 would have the maximum your laser would allow. That would be plus 6 in this patient with the entire cylindrical power of 2.5. And treatment 2 would be the residual spherical power what is there. That would be 1.75. Few other things, you keep the optic zone same in both treatment 1, treatment 2. Keep the ablation zone same. Go ahead, please. Next slide. And thing which we generally do with all hyperopics is correction of angle kappa. So we manually decenter the treatment, and this patient, the decentration was x minus 300 and minus 100 in the y-axis, and keep this also same in both the treatment. And the only other variable which you would not know is, can you go to the next slide? Is the K reading. So obviously for treatment 1, we put the patient's own K1 and K2. And what do we put in for treatment 2? So we just analyzed around 15 hyperopic treatments. So the left side, these are 4 patients for an example. The left side are the pre-hyperopic treatment. The middle one were post-hyperopic treatment. And the third is the difference maps. So we realized that every diopter of treatment in this machine would cause around 0.5 to 0.6 steepening. So for these double ablation patients, we put 0.5 to 0.6, added it to the baseline K, and that would be our baseline for the treatment number 2. So after this, the surgery would be same. Most of them were flap LASIK, and I think one was a PRK. You do ablation 1, immediately your technician goes to ablation, shifts to the second ablation, and similar to a regular case. So if you can go to the next slide. So this is a pre and post of the same patient with 7.5 and 2.5 cells. They seem to have very good results. The first one shows the poise PET function. The second one shows the steepening caused by your high ablation. And the third one is a visual simulation. Can you go to the next slide? So we have had around, I think, 8 cases now, and we have had quite good consistent results. All of the 8 are extremely satisfied. And a big disclaimer would be these sort of treatments are not FDA approved, nor approved by your machine. So the onus is on us. So case selection is extremely important. So all these patients, we made sure the baseline case were flat, because you're really going to steepen up the cornea and you don't want to induce extremely prolate higher order ablations. And small pupil is again very important, because whatever higher order ablations you're creating really doesn't matter when your pupil is around 3. And I would say the most important is to see if he's a perfectly type B personality, because you are doing something a little unconventional, and he should be ready to accept a small residual under or over correction. But I would say of the 8 patients, 7 of them are glass free. Only 1 patient has a regression of maybe around plus 1.25, which was operated 5 years back. So this was something different that we have tried, and I thought I'd put it up here. Thank you.
Thank you, Dipti. And Rishi, can you take over from here and give your comments, and then we'll have discussion.
So Krati and Deepti, both your presentations were very innovative and very interesting. I'll start with Krati's case. It was obviously a case of post-PRK haze, but unfortunately it was a very irregular haze with a little 2 hills with a little central island, and that can be a very challenging case to treat. And I must compliment for the accuracy with which you managed to do the PTK. I think that's only possible with the Schwinn. I'm sure you use the Schwinn MRS. And then you topped it up with a topography guided PRK. But my question to you is, how did you calculate the topography guided PRK and not ensure that the aberrations of that central island were not contributing to your treatment? What did you do for that?
So the pattern of ablation is based on your topographic profile that is captured in the CIRRUS map, and Schwind has that particular customization. So you can also track it while planning the treatment. And based on that, we had profiled the patient, and also using the depth minimization profile, we could customize what abrasions we are treating. And preoperatively, as we had seen, when the SA and trefoil was more, we decided to treat those in our patient.
If what I would have done for this case probably would have been a little different. I would have done a manual debridement of those things because it was very clearly above the ablation zone, and probably use a burr if necessary and manually remove those, and probably do a laser treatment as a second sitting if it was needed at all. My guess is it may not have been needed at all if you just did a manual debridement. And of course, you would have had to use a mitomycin C. So that's the only different thing which I would have done, but otherwise it was very well managed. As far as the second case, and another point, the accommodation exercises and orthoptic treatment, I mean, I don't have much experience with that, but my guess is it could also have been just, you have given time so the epithelium kind of smoothens out a lot of things. It could also have just been while you were doing the exercises for orthoptics, the epithelium was also filling in all the craters and making it more smooth. So you might be giving the credit to orthoptics, but it might just be the epithelium being your friend, is my guess. Or
So
it could be a bit of both.
after 1 month, so we waited for that much time. And then that's when we decided we should just get it evaluated.
Epithelium keeps getting better beyond a month also, especially in these kind of irregular corners. But certainly I'm not discounting what you've done, and wonderful outcome. Deepti, your series is very interesting. I have not had the guts to go beyond 6 diopters. And my guess is that it's not that the machines don't have the ability to treat beyond that. They have particularly stopped it at that because there are concerns, and there have been reports that beyond 6 diopters, your chances of spherical ablation are much higher. You can end up with decentered ablations. Your haze is much higher, and regression, of course, is much higher. So I must compliment that most of your cases have had a very good outcome. And I think a lot of thinking has gone into the planning. I would probably have done a refractive lens exchange in your case, in your set of cases, but very good series, and you should have it.
Sure, Dr. Rishi. Thank you.
So, Rishi, if I may ask you that topo-guided treatment, now many times the topographers, because the topographers are going to take a topo-guided treatment is basically Placido-based topographer treatment. So they're going to take from the first Purkinje image. Now, many times if the scars are as superficial as Krati's case was, the TFL may not be very stable and your topographic pictures are not very reliable. So how do you do a topographic treatment in such kind of thing? Would you do a direct topographic treatment, or actually you answered that you would rather do a two-step and where you would make it more regular and then try to do, if at all you want, topographic treatment or something? Can you just...
or you'd have to use a masking agent on top of the epithelium and then treat, possibly. Maybe do a PTK.
So, yeah, I think Rishi had very valid points that if your irregularity is on the surface, your topography is going to be very irregular. And you may find it very difficult unless you use a masking agent. So if it is anterior to your basement membrane, just a de-epithelialization itself will make it very regular. And then you can do your treatment. If your scars are much deeper than that, then your direct refractive treatment like PRK or PTK and those things may work much better. Dr. Sujata, if you have a case like irregular cornea and you're going to do a topo-guided treatment, do you always, and patient has a residual refractive error or some refractive error, do you combine refractive error with these cases, or you just do the treatment first? How do you manage this thing?
I would, my first thought would be to correct the irregular corneal surface. So I would really not really bother too much about the refractive error. If it is possible, after correcting the irregular corneal surface, if still the irregularities not significant enough that you can still do some amount of refractive correction, then probably I would like to combine it. But if
So
the
you counsel the patient that they may require 2 treatments.
Absolutely. If there is depth of ablation is too much, much more than what I would like, then definitely I would not combine it with the refractive procedure. I would just try to correct the, see, these are the patients who have had refractive surgery done and they come for a cataract surgery workup and then you see a decentered ablation. So my thought would be just to correct the decentered ablation, make the corneal surface regular, and then you go take them up for cataract surgery. Then you have a better idea about their post-refractive status. But very rarely, you come across, nowadays, because of the excellent eye tracking systems available, we really don't see much of these cases. But I have come across a few of patients where I've just done the correction, very little bit of refractive correction, but more of a surface correction just to regularize the corneal surface.
So, Dr. Nikhil, one question to you. Now, as Rishi was mentioning, this can very well be a Salzmann nodular degeneration. Now, in Salzmann nodular degeneration, as Rishi said, can we just de-epithelialize it? How often these kind of things recur? Do they recur, or these things don't recur after epithelectomy? Or would you use mitomycin C in de-epithelialization after de-epithelialization?
The Salzmann do recur. What I have seen, sometimes after years they come back. Whether the mitomycin C helps or I don't have access to any sort of article or I haven't read much about it, but probably I think it would be wise to use because they do come back. At least what I have seen or I have done some of these cases, they come back sometimes after even a few years. There's again degenerative change. But I don't know if there's any literature which is actually compared. If somebody has access to or read it,
yeah, that's very interesting for everybody to remember that even if such kind of cases you do de-epithelialization, there are chances that they can come back. Rishi, if we are talking about such, you're muted. Yeah, so if such cases like say we do PTK or something, so do you combine mitomycin C with PTK? I mean, is there a role of mitomycin C with PTK? We always talk about PTK with, mitomycin C with PRK, but what about with PTK? And what would be the dosage and duration there?
So, I mean, any ablation in the stroma can lead to haze, whether it's for PTK or PRK. So if my PTK is going to be 50 microns or more is when I tend to use mitomycin C. Of course, it also depends on the indication. If it's like a an eye which has been operated earlier, I will use mitomycin always, like a post-RK or a post-DALK eye. But otherwise, if it's for a recurrent corneal erosion, I'm just doing 15 microns of ablation, I'm not going to use mitomycin.
Bhaskar, any inputs from your side?
I mean, for PTK or for PRK for more than 40, 50 microns, like what Rishi said, I would definitely use mitomycin. Dosage would be similar to what you would use for your PRK. It's basically based on the depth of ablation and the area of ablation that you are ablating, because that is what is going to cause your inflammatory fibroblasts to come in. As far as the previous thing of combining refractive surgery with a PTK or a PRK, unless you understand how much your irregularity of the cornea is contributing to the refractive change, it becomes very difficult for you to assure the patient that you will end up with a refractive neutral situation. So for that, you have to be absolutely certain as to how much of the change in the topography which your laser is going to induce and what is the amount of refractive change it is going to create. If you have primarily a cylindrical component and your laser is going to cover it, it's probably going to take care of the coma, and you can be more sure as to what, like in a keratoconus patient, when you're doing a TCAT CXL, you look at the topography, you have some idea how the topography is going to change, and then you can decide on your refractive correction based on that. but that's easier because you're not assuring a patient of refractive neutrality. When you're dealing with a post-classic patient, the patient expects neutrality. It's better to tell them it's a two-step procedure. Try to correct as much as possible in one. If he is happy with that slight 0.5, 0.75 residue, you are happy, he's happy. If not, you always have a second chance.
Great. So first treatment has to be topographic guided when there is irregularity. The second treatment can be either wavefront optimized, or if we have, again, we may not have too many laser platforms, and if you have wavefront guided platform, you can use second treatment wavefront guided also. So with this thing, I'm going to hand over proceeding to Chintan again. Chintan, can you take forward the next case?
Yes, thanks, Dr. Himanshu. And can we have the next case by Dr. Sayali, please?
So good evening, everybody. So in the beginning, I just want to acknowledge LVPI Visakhapatnam to allow me to present this case. So this is a case which I have managed when I was working there last year. Next slide. So this is a 32-year-old male who underwent LASIK surgery for myopia 1 year back and had good spectacle-free visual outcome post the procedure. So he presented to us with a history of left eye firecracker injury and followed by drop in vision in his left eye 2 weeks back. When he presented, he was using eye drop prednisolone acetate 1% 4 times per day in his left eye, along with eye drop brinzolamide, timolol, maleate, and oral acetazolamide since 5 days. Next slide. So right eye had unaided 20/20 visual acuity and it was normal. So visual acuity in the left eye was counting fingers close to face. There was mild congestion in the eye. The LASIK flap was in place, but there was a diffuse haze in the flap. There was large mydriasis and lens was in place. Next slide. On the slit examination, there was microcystic edema and the LASIK flap haze with haze in the interface between the flap and the residual stromal bed. The posterior stroma was relatively compact. On high magnification, a clear space was noted in the interface, suggestive of a fluid pocket. This was confirmed on the anterior segment OCT. Next slide. The left eye intraocular pressure was 16 millimeter of mercury with Goldman applanation tonometer. However, since there was a suspicion of high or elevated IOP due to microcystic edema, flap haze, and interface fluid, applanation was repeated on the peripheral part of cornea, but we could not get a reliable reading. In such cases, IOP measurement is recommended with a tonometer like TonoPen, but we did not have TonoPen available. So IOP was estimated with digital palpation and it was found to be high. So patient was administered injection mannitol. Post-injection, his visual acuity improved to 125. The microcystic edema reduced and the posterior segment was visible and showed dispersed vitreous hemorrhage. So a diagnosis of left eye interface fluid syndrome due to elevated IOP, status post closed globe injury, and steroid response was made. Next slide. So the topical steroids were discontinued and patient was shifted to a non-steroidal anti-inflammatory eye drop. The anti-glaucoma medications were continued and patient was asked to review after 1 week. Next slide. At 1 week, the visual acuity in the left eye had improved to 20/50. Slit lamp examination and ASOCT images showed resolution of microcystic edema. The fluid in the interface had disappeared and the interface had closed. The intraocular pressure with applanation was 23. It was high, but the actual value could be even higher than this. So we decided to continue the same treatment. We continued the anti-glaucoma medications. Next slide. So at 4 weeks follow-up, visual acuity further improved to 20/30. There was no interface haze or fluid. Gonioscopy showed normal angle. IOP was still high, so one anti-glaucoma medication was added. Over next few weeks, IOP stabilized to normal and the vitreous hemorrhage also resolved. At the last follow-up at 17 months, the patient's unaided visual acuity was back to 20/20 and IOP was normal and he was already taken off anti-glaucoma medications 6 months back. Next slide. So I would conclude with these take-home messages. Next, just wait for the animations. Don't show everything at once. Okay, so post-LASIK interface fluid syndrome can be a delayed presentation. Presence of microcystic epithelial edema and flap edema are clues to interface fluid syndrome secondary to elevated IOP. So in case of IFS, due to endothelial dysfunction, the edema is usually more in the posterior stroma. IOP with applanation can be underestimated due to fluid in the interface, corneal hydration, and thinner pachymetry in these eyes. So target IOP needs to be adjusted accordingly. IOP measure, next slide, next animation. So IOP measurement with tonometers like tonopen on the peripheral part of the cornea is recommended and more preferable than GAT. Next slide. So topical steroids in these cases can be avoided as in closed lobe injuries, the inflammation is usually mild and risk of steroid response or glaucoma because of other mechanisms is more. A topical non-steroidal anti-inflammatory drug could be a better alternative. Thank you.
Thank you, Dr. Sayali. Dr. Ashish, your comments about the case, please.
Thank you. I think that was a very well described case, and I think it's a very important entity, the pressure-induced stromal keratitis. So I think it's what is important here is that I think as a refractive surgeon, if you see a case post LASIK, especially, the important differential is to differentiate it from something like a diffuse lamellar keratitis, which is an inflammatory pathology, which we all know will have different signs of granularity and inflammation. You may see cellularity in the posterior stroma, while in such cases of pressure-induced stromal cases, that would not be there, which you have very well described, that you may see some microcystic edema anteriorly, and the posterior stroma will be fairly clear. So I think these are the two clues, and it's a very important differential to keep in mind. And thus they may present pretty late, because I remember we having a case of one of our LASIK cases who had an RD surgery, and after vitrectomy, he developed decrease in vision, and then it took us a day for us to realize that he has developed pressure-induced stromal keratitis.
So the potential space always remains a place where fluid can collect, and which is why after any surgery or intervention, when the pressure rises, we can expect this. And I think retroillumination and seeing the microcystic edema, like you pointed out, is something which can really help differentiate between DLK and pressure-induced stromal keratitis. Dr. Geeta, would there be any preference for which topical anti-glaucoma medication to start with in these cases?
Dr. Chintan, can you hear me?
Yes, please.
Yes. So I think Saili has described the case very well, and they required management with multiple anti-glaucoma medications. For the few cases that we have seen, we have used either topical beta blockers or systemic acetazolamide to control the intraocular pressure. It's important that you bring down the pressure at the earliest, because you don't want any permanent haze to be left behind due to the non-control of intraocular pressure. And rightly so, they had to use IV mannitol also. It was done, but classically, in fact, currently I'm dealing with a patient with high intraocular pressure post LASIK at 3 weeks following the surgery. -8 was the error that I corrected her for. And she was plano 6.6 on day 1, and she came with a slight myopic regression at week 2 when we suspected high IOP, checked it, but it was within normal limits. And at the end of 1 month when she came, she had a -1.75 regression. And that time her pressure was noted to be around 38 in one eye. So when you have, and we started her on systemic acetazolamide, 125 milligrams 3 times a day. So with which the pressure should get under control. Usually it does come under control, especially with the discontinuation of the topical steroids also. So we have a concoction of anti-glaucoma medications that are available to us. Most importantly, it's important to identify the condition, stop the steroids, and start the AGM.
I think that's really important, because sometimes people confuse it with the DLK and then hike up the steroids, which further worsens the condition.
Yes, because it's a double-edged thing. I mean, the treatment for DLK worsens your interface fluid syndrome, and therefore you have to have a high index of suspicion. The worst cases are actually those where your AT is on the lower side when you have the cushioning effect of the interface fluid, and in that situation you actually need to measure the pressure on the peripheral cornea using the tonopen, and that gives you a more accurate measurement of the high pressure rather than the central GAT where you have the fluid. So it's important that you measure it in the periphery.
So I think that's again really important, because that low pressure can be really misleading.
Yes, and it's also important to remember that it's not just high intraocular pressure which can lead to interface fluid, but even an endothelial decompensation later on in life at any point in time following LASIK can also lead to interface fluid syndrome. So any patient who might develop an endothelial compromise later on may also develop, the problem.
Yes, okay, so Fuchs endothelial dystrophy and those, which is why
Yes.
looking at the endothelium preoperatively
Yes.
is again.
In fact, there are reports of patients who have had this long-standing interface fluid and then they've had a DSEC done, after which the interface fluid still didn't resolve when they had to go and lift up the flap to actually cause the resolution of the interface fluid, because they say that over a period of time, if it's been present for a long time, then you can actually have scarring occurring along the flap edge, which acts as a mechanical strut, preventing the space to go off just because you've corrected the endothelial dysfunction.
Yeah, that's an interesting point.
Curiously, does it ever happen to DALK patient? I'm not sure. I've not heard DALK patient. Can it happen?
In a DALK patient, you probably get the flap goes off, right? So you may not have the interface at all in a DALK patient. You mean to say a DALK who's undergone a
yeah, so somebody who's already undergone DALK. So you have near descent DALK, or you have DALK where you have some sort of interface. Does it actually ever happen that fluid get collected there with the steroid response? I'm not sure. I've not heard.
Yeah, I've not seen, but I think what you're saying is true, that even for this pressure induced, initially there would be an interface swelling and slowly the fluid will get. So maybe in the posterior stroma that may not occur because of the anatomical.
It's very interesting.
So sometimes we can have this dilemma where we are treating a DLK and we are treating it with steroids, and it leads on to increased pressures. So Dr. Ashish, how would you suggest a case of DLK leading on to PISK?
I mean, as in if you're treating an actual DLK and it is leading to PISK, that would be a really tough.
Just increase
That would be tough, and you'll have to balance both the steroids and the AGM to decrease the inflammation and also keep the pressure under control till it reaches a point where you can get the patient off the steroids. I think one thing would be to shift to softer steroids, of course.
How about the role of oral steroids in such cases and tapering the topical steroids?
I think in such a situation, I would try and do that as well, but I don't know how effective it may be.
Because sometimes in other ocular inflammations also, where we don't want to load the corneal tissue with topical steroid, we do give systemic and taper up the topical. So any comments from any of the panelists?
But I have no experience.
I have one question. I just want to know how long do you use steroids post LASIK? I have a very short course of steroids. I use it only for a week and stop it. So this was after I had my first PISK 20 years back. I didn't, and that time there was no reports about PISK, and then I was loading the patients with more and more steroids, and then I realized it's because of interface fluid. So since then, my regimen is only 4 times a day for 1 week, and I stop it. What about the others? What is your regimen for LASIK?
I use it for 2 weeks. I mean, not 2 weeks, 12 days, 3 days tapering, so 12 days.
I think with the femtosecond laser, we need to use it a little more, ma'am. That's what I feel.
On the first day, I do 1 hourly, the first day. And then I make it 4 times a day for 1 week. That's it.
I think one thing which I believe, which we are wrongly blaming femtosecond laser for, is that peripheral DLK, what we see, is more to do with the configuration of the flap on femtosecond laser. It's a vertical cut. So there is a gap, there is a gutter which is much deeper in femtosecond, whereas the tapering cut of a microkeratome epithelium heals within a few hours. Whereas the vertical gutter, which is there in femtosecond, the epithelium to cover that takes much longer time. So that's the reason why that stroma, which is open on the vertical wall of that cap, can lead to DLK in the peripheral part of the thing. It's going to heal once the epithelium is healed. So it's not the laser. And mind you, if we just change the configuration of the cut, and if we make an obtuse angle, even in femto also, I'm sure you would not see such thing. But with the current configuration, I agree with you that we may have to keep the steroid a little more in the earlier days.
But if you pop them with steroids in the first day, 1 hourly, and that gives enough coverage because it doesn't allow the PMNs to infiltrate, and by which time the epithelium has started healing. So after the second day onwards, you can go. If you don't see any DLK 4 times a day for 1 week, and then stop abruptly, no tapering.
So when you talk about steroids, topical steroids, here we are referring to prednisolone, we are referring to loteprednol. What is the steroid that you normally use?
Prednisolone. I use prednisolone.
Chloromethylone. Always.
So we use loteprednol. I guess we have all combinations here, and we use it for a slightly longer period of time. But we do know that these myopes are usually steroid responders, and you have to have your eye open for a high intraocular pressure in these patients when they are on topical steroids.
I guess that says that it's more psychological for us to use steroid than scientific.
In fact, I have known some surgeons here who use interface steroid, but don't use steroid for the first 3 days and then start. So it's a mix, I think, a very popular.
So I think as a take-home point, we kind of all agree that prolonged steroids are not required. Maybe a week to 10 days, 12 days is sufficient. And with that, I think, Dr. Himanshu, we can move on to the next.
Can I ask a question?
Yes, please.
Yeah, at what post-op visit you first document the IOP in a LASIK patient, considering that the flap is still there healing, and with what tonometer?
I think flap is not a problem. To lift the flap on day 1 also is very, very difficult. So flap is not going to dislodge by your IOP, but more of resistant to measure the IOP in post-op patient. Everybody, all the ophthalmologists suffer from that.
Non-contact. We do non-contact for all patients at every visit. So, I mean, anything more than 12, and I would be suspicious because they expect a low IOP in patients post-LASIK.
Yeah, I think non-contact is a fairly good screening tool. It gives you an idea of where you are. And if you see something high on NCT, then you can investigate further.
Which probably brings us to the question as to how frequently do you call your patients for a follow-up post-LASIK. So if you're seeing them on day 1, week 1, you probably have the option of doing all this. But if it's an outstation patient that you're going to see on day 1 and then on at the end of 1 month, then you probably have missed the time frame at which you can have a spike in intraocular pressure. So
we normally have a routine of 1 day, 1 week, and 1 month.
Yeah.
I don't know about the others.
Exactly.
That's exactly so that you don't miss that window.
Pre-COVID era, post-COVID era was some difference there.
And usually the spike in IOP occurs after a week. So it's that 1 to 4 weeks when you have that spike. So
that would be the critical period. Yes.
That's when I think most of us don't actually see the patients back in the clinic.
If the patient is not seeing, they'll come to you.
Yes. I mean, on day 1, if they are 6'6" and they have a raised pressure which causes blurring of vision, then they're definitely going to get back to you in some form or the other.
There is absolutely no need for steroids post 1 week because the epithelium is healed and there's not going to be much infiltration of pigments in the interface. So after 1 week, I think, I mean, to my this thing, I've been doing this for the past nearly 15, 20 years. I've not had any need for steroids beyond 1 week.
That's what Dr. Sujata, that's what we are saying. That's all these are psychological for us. It's like how we give topical acyclovir along with steroid and stromal immune keratitis. It's more to make us happy and maybe sleep peacefully. I think we'll go ahead with the last case. And can we have the case presentation, please? Dr. Vandana, can you have your case?
Yes. Next slide, please. So we have a case of a 38-year-old female who was interested in LASIK, and she had stopped her contact lens use about 1 year back. The power in her right eye was minus 5.25 sphere, 0.75 cylinder at 10 degrees, and she was improving to 6.6. And left eye was minus 7.5 sphere, 0.5 cylinder at 170, and she was improving to 6.6. Anterior segment was within normal limits, and fundus was within normal, and Schirmer's was within normal. Next slide, please. So her preoperative evaluation, the pentacam done in both the eyes were within normal limits and showed a PACU of around 555 microns. So she was advised to undergo both eye femto LASIK, and since she was 38 years old, she was also counseled about presbyopia. And the patient underwent the same, and surgery was uneventful. Next slide, please. So, however, on POD2, the patient presented with us with complaint of glare and blurred vision. Vision in the right eye was perfect. It was 6.6, whereas left eye, it was 6.12, improving to 6.6 parts. On examination, there was, the LASIK flaps were healthy, thereby ruling out any flap-related complications. So, the two things that we thought of, could it be either undercorrection or could it be decentered ablation? Next. So going back and checking the surgical parameters, the refractive error entered was right, and active tracking was on. It was enabled and auto-centering. Next. So we did a pentacam for the patient in the left eye, which is showing on the anterior sagittal map as well as the tangential curvature map. You can see the significant decentration that was noticed in this patient. In the right eye, the ablation was well-centered, whereas it was significantly decentered in the left eye. Next. So the Kerackonnect, the images, that is a Placido-disc-based images, showed a clear centration of ablation in the right eye, whereas in the left eye, it was again decentered. So patient was again followed up for, followed up again after 2 weeks, and the pentacam still showed the same values. And so she was planned to undergo a re-LASIK in the left eye. So the plan was to do a flap lift, a wavefront-guided ablation, and a LASIK extra to prevent epithelial ingrowth. And here, this is a screenshot of the eye trace image, the eye design image, which is showing the higher order abrasions as well as the ablation pattern. And she had significant higher order abrasions, majority of it being the coma abrasion. And the patient underwent the same, and surgery was uneventful. Next slide. So here again, patient presented to us again with POD2 with actually 6.6 parts vision. And you can see the central island and the ablation was much better post the resurgery. Next. So my discussion would be, why was ablation decentered in this case in spite of the active tracking being on? And second, the plus and minus of wavefront guided retreatment versus the topo guided retreatment in these cases. Thank you.
Thank you, Vandana. Dr. JK, can you give your comments here about the decentration and LASIK?
This is not quite common. This is once in a while we are seeing, maybe 1 in 500, 200 procedures. We do see patients not satisfied with the vision. Then we check carefully. We have slight decentration, but this is a very high decentration. And most of the cases, we are seeing this in higher diopters of power than lower diopters of power. One thing that came to my mind is because the fixation in higher diopters, more than 6 diopters, the fixation line, it's not, they're finding very difficult. Then why one eye, why the other eye? There's the question. Why the other eye is doing good and only one eye it's happening. Maybe it is ocular dominance, maybe they are dominant in one eye able to fix well, though acuity is good. The other eye, maybe non-dominant eye, is not taking up fixation very well. Then with eccentric fixation, the ablation also becomes eccentric. That's what I learned from the engineers. So another thing is came to my mind is there may be a small software bug. Once in a while, it's popping up in each machine, which we cannot control and nobody can control. So that basically the topo guided or wavefront guided, that depends upon the platform we are having. The V6 which we are having, not having topo grid link, maybe in Alcon or Schwind, when I had a Schwind, I used to go for topo guided because that works very well in Schwind. So that's my thoughts. I would like to ask Dr. Rajesh is here, or and what you do, Himanshu? That's this type of case.
Very, very interesting, Dr. JK. Decentration, though, it's not very common. Interestingly, some of the machines, like say Alcon we have now, Schwinn, they tell you after the surgery, they show you the map of the fixation, and they can show you whether constantly you were off for longer time, or was there a significant amount of fixation loss which this patient had. And very interesting to see in some patients where it's not exactly the center. The patient is not fixating from the center. Whatever you keep telling them that please look at the green light, or in your case you say red blinking light, the fixation is not there. And it's very interesting. We really don't know the reason. As you said, is it eccentric fixation, or is it something because they're not able to see the light clearly, or they are not very comfortable in looking at that. So that's one possibility. Another thing which can happen, especially the hinge area where the flap has not retracted properly, or if it has unfolded partly, what happens is there would be some amount of undercorrection where the fluid or meniscus would have formed near the flap hinge, and that leads to little part under treatment in that area, and which is something similar picture as a decentration, which is not truly decentered, but it's part under treatment which has occurred there because of that fluid which has got collected there. And as you rightly said, depending upon the platform you have, I treat it. If I have a platform which is giving me a wavefront guided treatment, I would rather go ahead and do a wavefront guided treatment. But if I have topo guided treatment, I would rather do topo guided. If I have wavefront guided treatment, I would rather go ahead and do that, because this would be the major amount of aberration which is arising. Hence, both of them would be pretty much similar in treatment. Dr. Rajesh, you want to?
Yeah, I think most of the points you have covered. The only difference between topo guided and wavefront guided is that the wavefront guided would also give you a refractive correction, whereas the topo guided may regularize the surface, but sometimes it may leave behind a residual error that you may need to address later on. Sometimes you have to be careful with the patient trying to fixate with the fellow eye, because because at the time of ablation they can't really see with the eye being ablated, so they try and fixate at that light using the other eye, and that can also sometimes lead to decentration, although it's not very common.
Yeah, that's what, as Dr. Raj has pointed out, that's what one of the scientists and engineers who worked for more than 25 years, he told me, once it goes to 1.52 diopters of ablation, the stromal surface becomes so hazy, it becomes non-refractile. He's saying that they can't see fixation light unless they are, the other eye being good, completely goes haywire, he was telling. Then that's another point they're telling. Then they are telling that the distance between the objective and the iris, this usually most of our missions are 200 millimeters. Of course, this is 160. That also depends upon the eccentricity of going away from the pupil. The third thing is I'm requesting them to give the active eye tracking now is 1.5 millimeters on both sides. Beyond that, it will stop. I'm requesting them to give a adjustable by the surgeon, because now the missions are very fast, whether we can reduce to 0.75 so that the range is only 1.5. Beyond that, it will stop. It won't fire when the patient goes.
JK, how do you manage cases which does not have good fixation? Like somebody has nystagmus, if you're doing LASIK, how?
Yeah, they are doing very well, as you're telling. They are actually, we know before, they're having fixation, amblyopicai. We hold with the forceps, the conjunctiva, and hold it. Actually, they are getting beautiful centrations. They're better than auto fixation.
You can safely hold the conjunctiva both sides and keep the eyeball straight, right? It can be done.
Yes, yeah. This, because it's only taking now, fissions are very fast. They're taking only few seconds, and they're giving very good results. Actually, they are doing much better, you feel sometimes, than auto centration.
You can apply the suction ring without the suction. just placing the ring also stabilizes rather than trying to hold with the forceps, which gives a point, fixation. Just apply the suction ring on the limbus, and just you can stabilize the eye, and you can do the laser ablation. So you don't have to switch on the suction, but just place the suction ring.
Stabilizing ring. Also, one more way of avoiding this is closing the other eye always, because that's what I do. I always close the eye which is not being operated. So the patient will tend to start fixating only with the eye which he has to fixate. So that's one way of avoiding a decentered ablation, and also positioning the head and some small features like that, keeping the chin straight, taking a little bit care before you start the procedure.
Bhaskar?
I mean, basically, most of the points have been covered. I mean, the few patients where fixation has been an issue, say we were for refractive correction, we've held with either the epilastic or the LASIK microkeratum, just placing it on the eye to fixate it. And for nystagmus patients, you can actually do a trial run to see whether, even with that limited amount of movement, is your eye tracker fast enough to kind of detect the pupil. In that case, you might not have to hold on to the eye. You'll be able to go ahead with the procedure. So these patients, better to just have a dry run under the LASIK microscope to be sure that your tracking system is going to function, or be prepared with an alternative to stabilize the eye.
Dr. Vandana, was this flap well centered, or was it a slightly decentered
Yeah,
flap?
perfect. Luckily, it's well centered, and there is no hinge ablation. The entire thing we measured, entire thing decentered by x by -1 and y by -1.5. It's for me still I am having a thinking that there is somewhere software bug. The auto centering wrongly went went ahead, but the data shows very good fixation. Everything is fine with the report.
If I could ask a question, this patient, you said flap was well centered and there was a decentration of the treatment. What if your flap itself was decentered and you had gone ahead with the treatment, and now you have to correct the astigmatism? Then you would have preferred a surface ablation to correct the astigmatism?
Yes. We do a surface ablation. Those cases we had very rare in the early days of when we are over enthusiastic. We don't want to cancel cases, and few cases we do a surface ablation.
How do you handle an ablation when you have air bubble in anterior chamber where your pupil tracking is not happening?
We had few cases, early days of femto. Sometimes we send the patient back, and sometimes we dim the lights a little bit. A lot we have to dim the lights. Then the pupil, if it's small air bubble, the pupil goes beyond the air bubble, then it will track.
You can put a drop of cycloplegic or put a drop of dilatation drops, and it just starts dilating and the air bubble is no longer in view. You can quickly do the surgery. That's what I've done.
But rare. Once in early days, of femto we had, not now.
No. Now sometimes you get these air bubbles, and you can.
I mean, I must say that I have got even lately, as late as last week also. So again, different machines are behaving differently. Alcon has tendency of air bubble anti-chamber, but again, individual machine also behaves very differently. Your particular machine behaves in a way, it has its own mind. My machine will have its own mind. Dr. Sujata, how significant decentration is worth treating? When would you touch up the case?
I would worry about it only if the patient is going in for a cataract surgery and wants a premium lens, because if the patient has lived with it for 20 years and has not complained, we do see quite a lot of patients in Chennai, because we were probably the first people to start examer laser. Dr. Babu Rajendran started examer lasers, and those patients, those days there was no eye tracking. And he has treated 12 diopters, 20 diopters and all that. So we do see quite a lot of patients in Chennai coming for cataract surgery with no complaints. Believe me, they're so happy. So why would I touch them unless I need to do a premium lens, and I'm not able to do the calculation because the decentration is quite significant.
Ashish, if you have a person who has come with decentered ablation and has some refractive error also, so how do you counsel them? Do you treat both of them together and you would enlarge the optical zone, or you do two steps, of what will be your take on that?
So you're saying that he has a decentered ablation and he needs a
It is residual error also.
Residual error as
He's
well.
come for the residual error. You just incidentally found there is a decentration. Now, how do you treat that?
That would be a difficult one to counsel the patient, because it would purely depend on the what the patient needs. If he's come for the refractive error, I would first try and bring his expectations a little realistic. But from what you're saying, I would probably go, if he's purely for the refractive error, then I may just go ahead and do the refractive correction.
So even if it's a decentered ablation previously, you can just go ahead with the refractive correction.
If he's for the refractive error, I will just go by the patient's subjective refraction.
Sure,
and if
sure.
he's not disturbed by, he doesn't have any symptomatic or aberrations, although he may have a lot of those things, then I would not disturb anything else and just do a refractive correction. But as I said before, I would really like to first talk to the patient and bring his expectations.
I think important part what you said was that counseling will be very important in these cases.
It could go either ways.
Bringing down their expectation. So two ways we can treat it. We can have, if you have topo-guided treatment available and you are doing part refractive correction along with the topo-guided treatment, that's one way. Some people may want to do a two-step procedure, like Dr. Sujata said earlier, that enlarge the optical zone, see the refractive changes, and second time come back again. But patient has to understand they will need multiple settings. Any other comments from any panelists?
Himanshu, just one point, in the sense that if somebody has a decentered ablation, so they are not worried about the refractive error. What they are is the glare and halos that they see because of the decentration. So in such patients, depending on the amount of corneal thickness that I have to play with, my primary objective would be to regularize the cornea and make the cornea more uniform, take away the high order aberration. That little bit of refractive error, I'm pretty sure most patients, once the disturbing halos go away, they are willing to even go back and wear that minimal refractive correction. So I think we should not aim at doing both, because doing, especially at least with topo-guided treatment, trying to achieve both simultaneously to regularize the cornea and do a refractive correction, sometimes you can make an error in your calculation and end up with a different refractive error despite having a smooth surface. So I think in that scenario, a two-stage approach is always better.
Rishi, you were trying to say something. Yeah.
I think I was just going to say what Dr. Fogla said, that I will focus more on enlarging the optic zone and regularizing the cornea. And I would do it on the surface. I would not lift the flap.
Sure. I was referring to patients like how Dr. Sujata said, that there are plenty of patients who are out there. When you see them, they don't complain of glare halos. You're incidentally seeing that the treatment was, and especially higher myopes where people had reduced the optical zone, you do find that that's not an earlier treated. They're not complaining. They are complaining about refractive error only.
Yeah, but your refractive correction will be very unpredictable. So
I agree.
I would rather just tell them that you have this problem. I'll show them the map, and I will tell them that
that's what Ashish said, that counseling would be the most important. Your chair time is going to increase, and I think that's the important part of them, for them to understand this. Yeah, Bhaskar.
Basic thing is, if the patient is absolutely asymptomatic about the halos and glare to a large extent, then even the decentration that we are seeing is probably not as significant. And if you have to regularize it also, the amount of ablation that your laser is going to do is probably not going to be that high. So in that case, you need to know how much of ablation the laser is going to do to smoothen your surface. That tells you what is the refractive error that the laser is going to induce. Then you base the refraction that the patient has and then plan for your final correction. So if the patient is asymptomatic, then the smoothening is actually not going to cause too much of a refractive change as such. That would be my thought, because for the laser to cause a significant, for the glare and halos to be significant, you will need a significant amount of laser to improve the contour. If that is not there, then the difference is more what we are perceiving. Objectively, probably the pupil or pupillary size or something is actually making them see through an area which is reasonably comfortable. And even if you have to expand the zone, it's not going to be too much of a refractive surprise. But it's something that you need to always tell them, keep it planned for both eyes. Two settings. Do the first. If you are able to calculate and get somewhere close to you, ideal, like what was described for the contour eyes. If your topo guided refraction with a planar refraction is about 10 microns or less than 15 microns, your axis of astigmatism is matching. If you're getting somewhere which is close, you might probably aim for a refractive. But if it's not matching, then you probably do it as a two-stage procedure.
Any other comments from any panelist about any cases?
I just have one comment, Himanshu. This is regarding Dr. Deepti's case, hyperopic correction.
Yes, I think we didn't discuss it much. I think, yeah, please. Yeah.
Hyperopic correction, there are a lot of literature showing that you do a cross-linking after the hyperopic correction, the stability is much more. So I have tried 6 diopters and with cross-linking. The only problem that I faced was that the patient had a severe DLK, and it took quite a while to go away. But the patient had quite a stable reaction, and I have for about 3-4 years follow-up, he's doing very well. But beyond 6 diopters, I've not corrected. So probably she can add on this. If she finds the results are good, she can probably add cross-linking also, so that there's no regression. We all know that hyperopia beyond 4, there is definitely the chance of regression is very high.
I have a little different take on this thing. According to me, hyperopia is not a one single refraction. It cannot be, because it's a dynamic situation where your eye is constantly accommodating. So hyperopes, depending upon your cycloplegia, can see somebody may have +4, but they may be able to, like a child, if you see them, they are 6'6" without glasses. You give them +1, they would be able to read 6'6", +2 6'6", +3 6'6", +4 6'6". So what exactly is the true refraction there? Now, you cannot do a total cycloplegia and treat total refraction. Patient will not accept it. So you will leave behind something. After a while, patient would not be accommodated that, and then it will show up, and we start taking blame at it's a regression, or my LASIK procedure is not working. I think it was meant to be like that, because it's never a stable refractive condition, hyperopia.
The so, late hypermetropia always comes up after a few months. The latent
so that's because they stop accommodate. The regression I would only claim when there is topographic changes which are occurring on the cornea. If we are able to prove that topographically the surface is changing the curvature, of course I would accept that. Very interestingly, whenever we talk about refractive surgeons like to take blame of regression. I mean, we do not measure axial length. So we don't talk about progression of myopia, but we call everything regression, myopic refractive error regression. If you look at the literature, long-term regression, long-term topographic changes or K-value changes are not even 0.5 diopter, not even 0.5 diopter in 20 years. And there are large-scale studies. If you're interested, I'll throw the literature across. There are many studies which prove that even at long run, the K-value changes are not even 0.5, 0.75 diopter. And we still call all of them regression, myopic regression or something, because we will not measure progressive axial length. Pre-op axial length, if we don't measure, then we take blame of everything. Either it was something which we missed out. So if we had measured pre-op axial length, we could claim that, you know what, it's your eye which is progressing. It's not my laser which is bad.
Himanshu, I have seen cases where the epithelium thickening has induced 4 or 5 diopters of regression.
Rishi, so there is plenty of long-term outcomes of K-value changes in refractive surgery. And such kind of cases, as I totally agree with you, can be there rarely, but rare things are rarely, right? So commonly, it's something which we are not measuring, and we are taking the blame of that progressive myopia as regression of myopia.
Sure. So if I may add what Madam asked, like these were the cases where it's like a concept of deburking, where probably you would put a toric lens in a keratoconic eye to basically grossly reduce the refraction. So it was like, 7 to 8+% comes even to +1. That one is easily taken care, even if he regresses by +1. It's easily taken care of by his accommodation. Like you see a lot of these hyperopes, maybe 2-3 years later, your scope is showing something like 1.5, but they're reading 6.6 bang on. So even reducing the size of a +8 or a +9 glass to a +1 is very, very cosmetically satisfying. So it's just that particular group of patients. I think even a small regression, they're really not really bothered.
Yeah, but
So
actually is shown to stabilize. Probably you can add on, particularly when you're doing such high corrections.
Sure.
And just one more case, Himanshu, if you have time. Dr. Gupta's case on the peripheral ulcerative keratitis, Dr. Krati's case. That I think, I don't know whether she mentioned, I have seen a very similar case, and meibomitis was missed. So once we started the patient for marginal keratitis with steroids, patient regressed within a week. I put the patient on oral steroids because it was so dense and it was really frightening, like what she said. And probably that has to be kept in mind, patients undergoing refractive surgery, some of these patients do have meibomitis, and that is to be taken into consideration.
Sure, thank you. So with this thing, we come to the end. Before we end, I would like to profusely thank all my panelists, all the speakers who submitted very nice cases. Unfortunately, we could not have selected more than this number of cases. We still stretch. We were told about 10 cases we could safely take, but we added 3 more cases. Unfortunately, we had to refuse few of the cases, and few of the cases which were not fitting into this thing, like lens-based thing, we'll take it in future because we might have an entire separate lens-based refractive surgery later on. I would like to thank Dr. Geeta, and I would like to thank Shabina and the entire staff of Hallmark, and can't miss out Sun Pharma to support us with this venture. And please be aware that we will keep on doing. Dr. Nikhil has written a message that if you have any suggestion about the topics and all those things, please send it across to us and we'll keep in mind and for the future. I also would like to remind you that as we go by Kerackonnect 2 steps, this is one step where the cases were then, or rather I would call part 1. And the part 2, we'll come out with further dates, but it would be an interesting session where we would like to answer evidence-based answer to many of your common questions about how much we can correct with the PRK, whether mitomycin C, how much we can go. And so many interesting questions in refractive surgery we'll be answering, and it would we'll come out with the details in near future. Over to you, Dr. Geeta, for concluding remarks. And sorry, before I forget, I must profusely thank Dr. Chintan Malhotra for there with me, for being a wonderful co-host. Thank you, Chintan. Thank you.
It was my pleasure, and it was a wonderful discussion. Thank you.
Thank you, Dr. Geeta, please.
Thanks, Himanshu. I think this was an excellent session. We had wonderful cases, great discussion, great job done by both Dr. Chintan and ably guided by Himanshu. Thanks to all the panelists. And we have started this year with a really good Kerackonnect session, and we look forward to having more sessions this year. So with that, I think we can call it a day, and thanks again to everybody as well as our sponsor Sun Pharma for today's evening. Thank you.
Thank you. Good night, everybody.
Good night.
Good night.